Wednesday, May 12th Zoom meeting. Just want to welcome Dan Kane, our new member. I got the email from Diane. You're all sworn in and everything, right, Dan? And Kevin too. Good. All right, so we'll get started with the 7 p.m. public hearing on 9 Adams Street, Civil Solutions. I think Kirk's here to talk about the variance.
Yep.
Variance.
Can you hear me?
We can.
Good evening. I'm Kirk Fitzpatrick with Civil Solutions, and I'm here on behalf of Dave Gallo, who is the trustee for 9 Adams Street Realty Trust, and he's the property owner for 9 Adams Street. Happy to share the plan with you and go over it.
Hi, Jim.
So basically what we have proposed before you is a upgrade system for the existing 3-bedroom house. Zoom in a little bit here in the plan view and go over it. It's a pretty small lot. It's only 6,488 square feet. It's 69 feet wide by roughly 90 feet deep. Presently, it's got an existing 3-bedroom house here in the front that's serviced by town water and gas, and it's got a garage in the left rear corner, and it's got some kind of a leaching system in the middle of the backyard that's most likely a cesspool and would not pass a Title V inspection. So we went out and conducted 2 test holes. Zoom over to the test holes here, where we found some fill on top to about 28 to 34 inches. And then below that was a sandy loam. And the first test hole had a seasonal high water table at 2.5 feet and observed at 3 feet. And the next one had a seasonal high water table at 36 inches and observed at 42 inches, just because it had a little more fill on top. Because of the depth of, or the height of the water table, we're not able to run a percolation test. So we took a soil sample, sent it off to the lab, and it came back as a Class 2 soil. So the new system is going to be designed based on a percolation rate of equivalent percolation rate of 30 minutes per inch. Basically, what we have proposed is to come out to a new 1,500-gallon septic tank, and then that's going to feed a 1,000-gallon pump chamber, and then that's going to pump the liquid up to a system composed of the geomat. It's going to be 26 feet long by roughly 23.2 feet wide. With the geomat, it allows for reduction in the groundwater offset with approval from your board, and this is really the best system for the property, much like the other ones on Adams Street, just because it's so tight and the groundwater is so high, and the geomat has such a low profile and has a reduced grading requirement when it's pressure, it has pressure distribution applied to it. So basically this system, when the pump kicks on, the pipes in the field are small 1.5-inch pipes, and they all get filled at the same time and spray the liquid equally throughout the entire leaching area. So with that being said, I'd be happy to read off the approvals we're requesting. We're asking for approval sought from Littleton Board Health to allow for a reduction in the groundwater offset from 4 feet to 2 feet with the use of the geomat leaching system. We're asking for approval under 310 CMR 15.4051I to allow the use of a sieve analysis where a percolation test could not be performed due to groundwater interference. We're asking for approval under 310 CMR 15.451I to allow less than a 12-inch separation between the inlets and outlets of the tank and a high groundwater elevation. And the septic tank and pump chamber are required to be ordered with boots, and the risers will be sealed at the tops of the tanks. We're asking for a variance from Littleton Board of Health Regulation 27 to allow fill to meet minimum breakout grading requirements within 10 feet of a property line. So basically, when this system is built, at its worst point, the grade's going to come up about 1.5 feet over here in the corner. And then because the geomat has a reduced requirement for grading, it's going to only come up about 5 feet and then slope off quickly to catch the existing grade. So with that being said, the fill associated with the new system is going to be about 6 feet off the lot line on this side and about 7 in the back. And then lastly, we're asking for approval under 310 CMR 15.451B to reduce the requisite offset from the cellar wall to a septic tank and pump chamber from 10 feet to 6 feet. And that's being requested just because of the very limited area on the site to actually fit the components in the backyard. With that being said, I'd be happy to answer any questions the board may have.
Kirk, can you just explain your number 3 approval is sought to allow less than 12-inch separation between the inlets and outlets of the tanks in the high water
Yep.
ground level?
Be happy to. So basically, DP has a regulation that they want the inlets and the outlets of the tanks to have a 12-inch separation between the inverts and the seasonal high water table. But because of the grade of the land and where it comes out of the house, we're kind of limited on that. If we couldn't pick up the tanks high enough to meet that offset and still make them actually fit in the ground in the backyard. It's pretty common that we ask for this request, and the septic tanks now all come with a rubber boot cast into the molding, and then it gets actually clamped over the pipe to make a watertight seal. And then the risers that will be used would be actually butyl sealed to the top of the tanks. We shouldn't have any water intrusion. And these tanks, you look up here in the profile, they're actually going to be ordered to be monolithic and what are called H20 loading. So they'll have an extra heavy top on them also to prevent any potential for buoyancy. So what I mean by a monolithic tank, a lot of tanks have a seam that if you ordered a standard tank, it would have a seam down the middle. A monolithic tank is more shaped like a bathtub with a flat lid. So it's actually cast as a solid bathtub shape, and then the joint is actually at the top. So it gets a flat lid, but on the top. So it doesn't have any joints halfway down.
Okay. Does anybody else have any questions for Kirk? Kevin?
Kirk, are those tanks waterproof too? Do they have like a rubber coating?
They don't, but they're made to be watertight. I mean, they have to pass an ASTM standard for the suppliers to sell them. So they are watertight.
Are there any other precautions like, hydronic cement around the inlets since they're going to be 12 inches from the groundwater?
I think with the rubber boot that's already cast into the tank and then it gets clamped onto the pipe, I don't think the hydraulic cement's going to stick to the rubber very well. I don't think you can beat the rubber boot.
Okay.
I have a question.
Sure, go ahead, Mike.
You may have answered this and it slid by. It's a 3-bedroom, and what I'm asking is the process capacity of this system, can it handle 3 bedrooms?
Yes, it can. So down here in the design calculations, so basically, if you were to try to design a conventional system on this site, you need 1,000 square feet. But because the geomats is an alternative system, doesn't have any stone under it, it's actually bedded in the same sand that a Presby is, with washed concrete sand, the ASTM C33 sand. You get a reduction to 600 square feet, and you're not allowed to go less than 400 square feet. So with that being said, this system has 23.2 feet wide by 26 feet long to be 603 square feet. So the long and the short of it is, yes, it has the capacity for 3 bedrooms.
Thanks.
You're welcome.
There's a service contract too, correct?
No, this one does not have a maintenance contract associated with it.
I don't think most of the geomats do, correct? It's more the
That's right. None of the geomats require a maintenance contract.
mostly the shared systems that have contracts like that. Does Dan or Gino have any questions for Kirk?
No, thank you. We've seen some of those before, and I don't think we should have any problem.
Okay. Jim, do you have any comments for this?
No, as Kurt mentioned, Adam Street's kind of a challenging street to replace septic systems on. The things that it has going for it is that there's town water. So that makes it, you're not dealing with wells and worrying about well offsets. The challenging thing is the groundwater table is really high and the lots are small, perk rates are high. And so the geomat helps address, because it gets a reduction as it being an innovative alternative system. As Kurt was showing you, you can actually reduce the the system size, and that helps with the grading to try to prevent water from being, being shed onto abutters' lots. One of the other things that's nice about the geomat, or at least its approval, is if you're using it as a pressure dose system. So, if you think of a gravity system, the water would go into those pipes have a little bit of pitch, all the water goes to one end. And the breakout requirements, instead of being 2 feet out or from the edge of the system and having to slope down, you'd have to be 15 feet out with a conventional system. Pressure dosing puts the effluent more equally distributed over the leaching area, and that provides better treatment over time than the typical gravity system. So though you have to do a groundwater reduction to try to get the system to fit in there, the fact that it's pressure dosed makes it a more efficient system for the site.
Right. So you don't have a problem with this, Jim?
I do not. Nope.
Okay. And Kirk, you addressed notice to the abutters. Is there any abutter in the audience with questions? Anybody have their hands raised, Janet?
No hands are raised, Lisa.
Okay. All right. Any questions or comments before we take a motion? No. So do we have a motion to accept? That wasn't me. Can I get a motion to accept all the 5 variances that are requested?
Motion to approve the plan as presented.
Thanks, Kevin.
I second it.
Okay, so we'll go alphabetical order. At a roll call, Kevin Baker,
Kevin Baker, yes.
Gino Fratelloni,
Ferroni, yes.
Dan Kane.
Yes.
That's right. Say yes, not yay, right? And Mike Zeldin.
Mike Selden, yes.
Great. Okay. All set, Kirk. Thank
Great.
you.
Thank you very much. Have a good night.
Thanks. Good. And a little over, but we'll move on to the public hearing for 257 Goldsmith with Foresight Engineering. Scott Hayes, I see him here for variance request. Go ahead, Scott.
I am. Hello.
Hi.
So this is 257 Goldsmith Street, site of an existing single-family Meadowbrook Road. We've we've been out to do test holes here, and we were unable to run a perk test due to the saturated soil conditions, so we took a sample. So we're here tonight. We've requested a variance under local upgrade approval 310 CMR 4051I for sieve test in lieu of perk. A good depth of soil here. Soil came back sandy loam as it was classified in the field from the lab. So it was designed. We designed a replacement bed at 30 minutes per inch perk rate. So it fit in nicely. There's a little bit more room on this lot than some lots on the lake. So we were able to meet the 10 foot to the property line on the limits of grading, and actually able to get a gravity feed from the house, because the house sitting up closer to Goldsmith Street is at much higher elevation. So that backyard was relatively low. And when we elevate it to meet the groundwater offset for the field, we're still able to gravity feed it in there. So fit in there nicely. And other than the sieve test for the system sizing, it's fully compliant with the regulations.
So it looks like you're not changing anything. Is it still going to have many bedrooms in the house, in the existing dwelling?
3. It's existing 3. Existing 3. It's to remain 3.
Okay. So it looks like you're just changing the driveway and adding a garage.
Yeah, they're adding a 2-car garage and relocating the driveway off. They're removing the driveway on Goldsmith Street and bringing it out onto Meadowbrook.
Okay. Does anybody have any questions for this?
No.
Dan?
Would it be possible to
if you did not add the garage and move the driveway, to install a new system without a variance?
Well, it's just really a function of the groundwater conditions on the site. I mean, it was saturated. We had seepage coming in. We attempted to perk test it, but it was just too wet to accomplish it. And the garage wouldn't change that.
Scott, I think you're breaking up a little bit.
Yeah, I don't know if it's my internet connection or not. Everything's a little bit choppy for me as well.
Okay. Does anybody else have any questions for Scott? Go ahead.
What type of system is this?
It's a infiltrator as a high density polyethylene vaulted chamber, proprietary chamber. So
Because
it's a
your
low
application,
profile,
your application had the check box that it was IA.
it is, yeah. So it's an alternative SAS. It's not a crushed stone bed. It's a alternative leaching area, soil absorption system. Allows a slight reduction in footprint area.
What's your groundwater offset?
4 feet.
Does it make sense to try a Presby?
4. Did you hear that?
I heard 4. Yeah. Does it make sense to try a Presby?
Yes. Doesn't really do much for the site. No.
Really? Even just getting it down 2 feet?
Who's got the background? Is that background?
Sorry, probably me.
Yep, it was you. Jim, do you have a question? Can you answer that question for Kevin? This would be better as a Presby? Jim?
Presbys generally give you some benefit when the site has a bit of a slope to it. The area where Scott's proposing that leaching area is reasonably flat, and so you don't get a lot of benefit from Presby. And you know, the preference would be to maintain the groundwater offset if you could. And so this design allows the 4-foot groundwater offset to be met.
And because they reached the 10 feet, are the abutters notified?
Because they didn't get closer than 10 feet, they didn't need to notify.
Yep, okay.
Yeah, it's pretty big.
All right, does anybody have any other questions? Go ahead, Dan.
Quick question. So the current owner is Leon Sawin. Is this property being sold? Is this part of this, the rebuild of the septic, part of the sale process?
Yeah, the property has been sold. Green Hut Homes recently acquired it. They purchased it a few weeks or a month ago.
Okay, so I'm just looking at the application, and the applicant's name, owner or prospective owner, is showing a start to finish construction as the proposed owner. So I just wanted to make sure
they're the contractor builder, associated with Green Hut Homes. Solwyn was the owner. Now Green Hut Homes, which is a subsidiary of Start to Finish Construction, is the owner.
Okay, cool. Just want to make sure it wasn't clear.
Okay, so is there a motion to accept the variance as requested?
I make a motion to accept the variance as requested.
And somebody to second it?
I'll second that.
Mike, so we'll go by roll call, alphabetical order. Kevin Baker,
Evan Baker, yes.
Gino Fratelloni,
Beautiful, yes.
Dan Kane,
Yes.
Mike Zeldin,
Mike Zeldin, yes.
and Lisa Flanagan, yes. All set.
Thank you very much.
Thank you. Guess we're on to you, Jim, with your COVID update. How did your vaccine clinic go today?
It was good that it was slow. Unfortunately, kind of juggling between when the vaccine would arrive, when we would actually publish it. We had about 40 people there, so kind of a slow start. We hope that now that we know we have vaccine and we've got out the information a little bit sooner, that next week we'll have a better turnout. But it went well. We have the new software from the state, so it was a good opportunity to work out any kind of bugs. The site's new to us, so again, it was good for everybody who was working at the site to have a sense of how that was going to work. So all in all, I think it went quite well. So we're looking forward to continue doing it.
I was going to say, how long do you think that you'll be doing? Is it once a week, or in all ages and walk-ins or appointments, or?
So right now we have Moderna vaccine, which kind of limits the age of the persons that can come to the clinic. We would prefer to have as many many people register as possible. It helps us plan to have the vaccine there without and defrosted and at the site, so we don't worry about losing it or wasting it. We can do some walk-ins. One of the nice things is where it's just over at Devon's, we can scoot over to our office, pull the vaccine that we need and use it. But you're still chasing increments of 10 because Moderna comes in vials of 10. So you really, again, it's that nobody wants to waste vaccine. So we're always kind of juggling. And we hope people come to the clinic with lists of names if we get near the end and we've got a shot or two to put into an arm. So we are hoping to maybe move to Pfizer. Hopefully maybe by the end of the month. We have to see if we can get that. Part of the challenge with Pfizer for us, Pfizer vaccine comes in trays of almost 1,200. And it needs ultra cold storage for its maximum time frame. So if you have I think it's 60 to 80, negative 60 to 80 temperature, we don't have a freezer that does that. That gives you a maximum time to store 6 months. If you store it at 15 to 25, negative 15 to 25, you can store for 2 weeks. We're concerned about being able to use all that vaccine in 2 weeks. So we're trying to find someone to partner up with who can store it at the right, that ultra cold temperature for us, and that we can, as the clinic registrations come in, go grab the vaccine from that site. That'll give us the flexibility to go down to 12 shortly. And that's something we'd like to be able to do.
And I guess, I'm sorry, I didn't hear. How often are you going to do the clinic for?
Well, so we want to gauge demand. And so we'll see what next week brings, because it'll have a full week of it being out there. We are looking for some other partners to help with other days. And so, again, it's kind of a work in progress as we look at demand.
Right. Okay. Sorry to interrupt you. Go ahead.
Oh, no, that's okay.
Okay.
So with the COVID report, kind of a quick thing on the numbers now that I realize what day it is. Thank you, Katrina. So the number that I pulled off of the 2 week rolling was 16 for Littleton, so down a little bit. And then the weekly number, so the numbers through for the week, for me, that starts on Saturday the 1st. That's the week I have the complete numbers for, about 12 cases. Mike had asked me to do a kind of a dive into the cases, so I'll do that in just a minute. As of May 10th, there were a number of changes to the reopening plan. On our public health call yesterday, they had the Department of Labor standards there going through all the nuances of all the different changes and all the sector-specific standards. It's kind of dizzying. So again, my comment would be that if anyone needs to kind of review those standards, I'm more than happy to sit with them and go through the standards. Some of the significant thing is they've changed some of the way the cleaning parts are done. It's kind of back to regular and frequent and ordinary kind of cleaning. But there's all kinds of nuances that, it'd be better if I'm working one-on-one with somebody who had questions on that. So I'm happy to do that. One of the things I will say is the mask order. I don't know. So the governor modified the mask order outside. If you can stay more than 6 feet, you need to wear your mask. But there's exceptions in there, and people don't. When they hear the press conference, they don't hear the exceptions. And so it's really important to go take a look at the order. And one of the exemptions is that if there is a sector specific standard, you need to follow the mask requirements in that standard. So if you are having a big outdoor event, you need to follow the mask orders in the indoor outdoor event. Or if you're in the retail sector, you need to follow it in the retail sector. So there are some exemptions in the mask order that need to be followed. So again, if people have questions about what's required, I'm more than happy to go through that with them. To Mike's question about the Maven, what Maven was showing, what we had in the system, what I did was I took a look. I looked back a month, so from May 11th back to April 11th, there were 47 cases plus or minus in Littleton, confirmed cases. And 21 of them were at just a handful of addresses. And as you look deeper into them, we were seeing in that month period of time a large number of multiple cases, like 3s, 4s, and a 5. So going through a family. So did that explain some of the jump that we saw? Quite possibly. Other things I noticed as you go through the contact tracing notes in each of the records, most of the exposures, as reported in the records, are home. The people have gotten it at home or been exposed at home. The next biggest exposure that was reported in those cases were workplace exposures. There's a daycare in there, there's a college in there. So, but again, households, which has been no surprise, it's been that quite a long, right along. Workplace is a smaller number of it. One of the things that was interesting is they list vaccine, people who have been vaccinated in their records, so you can see who's been vaccinated. So of those 47 cases, probably about 20% or so had at least one shot, and probably 7 or 8% of them were doubly vaccinated, and at least a couple of them were fully vaccinated who still ended up getting COVID. One of the things you can do is they ask symptoms and they check off the symptoms people have. So as you're looking through the record, and what you could see in those vaccinated people, the symptoms didn't seem to be as bad. Now, this is a small number of cases. You're looking at the 47 cases, but so I guess the message about being vaccinated is even if you do get the illness, it's not going to be that as bad. And all of the vaccines that are currently in use in the United States are represented in the records. Plus, there was one case where somebody was fully vaccinated with AstraZeneca. So, not that we administer that a lot in this country here. So, whether somebody's traveled or however the case may be, travel didn't seem to be a big factor in the cases. There are only 2 cases where travel seemed to be even mentioned. And one was within the states, one was international. About 25% of the cases or so seemed to be children. And sometimes it was, workplace coming home to the kids. A couple of cases, it was daycares coming home to the household. A lot of, particularly with the kids, asymptomatic. There was at least one mention of a family gathering as a potential for cases being spread. I don't know if there's, like I say, I think one of the reasons we saw that bump as I looked through the records, there was nothing other than families that seemed to be clusters that seemed to be causing these cases. As you look through the records, there didn't seem to be any connections. All the workplaces were different. Travel were different, kids, ages. So I think it would you had it going through a number of households, and not just 1s and 2s, 3, 4s, and a 5. So that, in a small set of numbers, that makes a big difference. So, Mike, I'm not sure if that's what you were looking for, but
well, actually, it not only was I looking for it, but there was another reminder here, which frankly slipped away from me a long time ago, and you've retrieved it. And I just want to double check, but the big news now, a piece of news that maybe has not been emphasized is that being vaccinated does not assure 100% protection from infection. But the other piece of it is that if you do get infected, the resulting symptoms are greatly reduced and the suffering is reduced. And I don't think we've talked about that. Maybe we have and it slipped by, but I think that's an important point about the value of the vaccination.
And again, in the Maven, in the checklist there, they're not talking about degree, but they have a list of symptoms, and then they have a little box for a narrative. And again, for those vaccinated people, the symptoms didn't, the congestion is described as stuffiness or slight cough. So.
For the households that it went through, though, or some of those individuals vaccinated and others not, or was it like a mattering? Because you said about half of them.
So 9 cases
were in households. So I'm wondering how that distributed.
So about half the cases that month were households.
Yeah.
And I'd be lying if I said I remember all of them, but I remember the 2 biggest clusters, and that nobody in the households were vaccinated.
Yeah, I was just wondering if it makes sense. People vaccinate in clusters, so it makes sense if a household's not vaccinated. Then the larger number of household, you'd have more people in that household who'd be a case. So that makes sense.
In the case of kids that aren't eligible.
Yeah, or you have a large family. Yeah. Yeah, makes sense. I mean, it's the same exposure settings that we've been talking about all along. It sounds like, workplaces, and it's out and about. And if you let your guard down, it's going to get you.
Mm-hmm.
Some of the limitations of that, again, as you go through the contact tracing and investigating notes, people are short with information. You can see that sometimes they either refuse to answer questions or they refuse to give us information about contacts. Again, your contact tracing is only as good as the information you're able to extract from the person you're working with. So I guess that is a kind of a caveat to the data.
For the most part, are people willing to come forth with information, or is it starting to be more resistant to sharing?
I was surprised how much information is in the notes. So most all of the records I looked at had some information. Some of the information was filled out. Yeah.
Maybe we'd like to have that versus the other. So.
Right.
Yeah, and you said memory too. I mean, and kids remembering who they were in touch with. They don't remember that they jumped on the trampoline with Johnny for 15 minutes, and All right.
And honestly, when you're doing contact investigation or tracing, we always tell people we aren't there, so we really rely on you. Sometimes, if you get multiple cases that you're working with that maybe were at the same gathering or something like that, sometimes you get other people who remember things differently. And we've had cases where somebody said, "Oh no, there was no contacts," and somebody else in the same situation said, "Oh yeah, I was in contact with that person." So those are uncomfortable sometimes, and sometimes a location has cameras, and we've been offered the video to show who was close contacts. So, yeah.
All right. Does anybody have any questions or comments for Jim at all? Let me move on to Katrina. Thank you, Jim.
Welcome.
Thank you, Jim.
Go ahead, Kevin. Got to be faster, Kevin.
Sorry, I'll be quick. Jim, what types of freezers, who has the freezers locally that you need for the Pfizer? What types of industries? I'm just always thinking. And
so when the state reps and senators were working to try to get us the collaborative, they were mentioned there's a business up in Pepperell that does some of that kind of cold storage. Part of the problem is they'd need to be a vaccine provider to be able to receive it, and they're not. So I've reached out to the Rutland Collaborative, the vaccine collaborative. I happen to know the health agent to ask if we could, they would receive the vaccine, and vaccine providers can transfer between providers. And so what we would try to do is set that up so that they could receive it. I just got to clear it through the state. They could receive it for us. They have a cold storage freezer. We could then go down and grab what we needed for clinic and come back and use that in the clinic.
So it's not the type of thing where you can rent one. And
I'm not aware of it, but we're going to check with the company in Pepperell and see if they have a mobile one and see if that's a possibility.
Oh, cool.
Yeah.
Thanks.
Jim, one other thing, I think, kind of jumping because it was I would probably consider it in correspondence, but I just got something about the Buyin X extending the expiration date. Did you see that at all?
Have not seen it. Nope. Expiration dates on the kits or the expiration date. Yeah.
I tried to print it up, but I'll look at it. I'll look at for my email and I'll send it to you.
Okay, great. Thank you.
Okay. All right, Katrina.
Thanks, Jim. That
Right,
was,
Ness?
can you hear me? Jim, that was really helpful. Thank you for doing that extra looking. All right, sorry, my whole thing rearranged again. Let's see what I can do. Okay. So we'll jump right in. I want to start off a little, I'm going to mix it up today, see if you guys are paying attention, I guess. So I wanted to start with just kind of reviewing some concepts about transmission so that so as we go through the rest of the metrics tonight, we can start talking about chains of transmission and susceptibility, things like that. So when we started the pandemic last March, everyone was susceptible. It was a new disease. No one had antibodies. So COVID was free to just spread through the chains of transmission. That's one of the reasons we locked down. We just couldn't figure out where it was. We had a lot of developing tests and things so we could start to understand where things are. So there's just a lot of work we had to do very quickly on that. And then we started opening things up and we're using masks and testing, contact tracing, all those things we were doing to help slow the spread, but that didn't stop it. So that wasn't a way to like prevent transmission. So as things went along in the time, we were making it slower to go from person to person, but we weren't preventing it completely. And then as more people became cases, we've started to have people who build natural antibodies through disease, having some immunity. And then in December, we started having people vaccinated. So slowly over time, the chains of transmission kind of changed. But just to keep in mind, as of today's date, only 10% of Massachusetts residents have been identified as a case. So that's very low. And while it's probably underreported to a certain extent, the message is still the majority of residents in Massachusetts did not have COVID and therefore didn't build natural immunity. So vaccination is our way to like really build this community immunity kind of protection. So Massachusetts is running this really robust vaccination campaign, and the number of people who are susceptible, each of these little gray dots, has started to change rapidly over the last month, actually. So when you think about community level immunity, that is when a large portion of a group becomes immune to a disease, either through natural infection and or vaccination, which makes spread from person to person unlikely. So natural infection may produce enough antibodies to protect an individual against future infection, but it also carries the risk of serious or long-term health impacts to that person. And also we don't know what's going to happen with the risk of reinfection or transmission for future infections. And then vaccines build immunity by training our immune systems to create antibodies. And vaccines create immunity without causing serious illnesses or serious complications for individuals. And often vaccine-acquired immunity confers a higher antibody response than a natural infection. Actually, that's what we're seeing with COVID vaccines, is that there's a higher antibody level among people who are vaccinated for COVID versus those who had natural disease. And the COVID vaccines have been shown to stop transmission to others, to really prevent spread. So this concept of population level immunity is also the point when no new chains of transmission can get started. So we're at a point right now where we keep having this replacement with the number of cases. We've been, we'll see in a second, we've kind of been steady for a while. So we can't, as we're getting more people vaccinated, we can still have spread if we can't get our numbers down first and then let the vaccines really do their job, kind of cover and suppress. So it's really just preventing new chains of transmission from starting. And then it's really important to know that community immunity protects everyone, not just those who've developed antibodies through infection or vaccination. It also protects those that are too young to be vaccinated, who can't get the vaccines for medical reasons, or just who choose not to if there's a small enough proportion of people in the population. So it's important to keep in mind that vaccinations may not be evenly distributed in any group of people. Like we've talked about, often groups of vaccinated or under-vaccinated individuals kind of cluster, such as families or social circles, age groups. So if you think schools, there are certain groups for our schools that are not vaccinated because of their age. So that's something just to keep in mind as we run through these statistics this week. So if we look at the state data, these are the 4 main metrics, and I will dive in, but I have to say overall, these are looking really good. So let's just get really specific. This is the number of tests. The number of tests have steadily declined over the last 2 weeks, actually since April break. It's just been this steady decline in the number of tests that are happening. So that could be that not as many people are exposed and need to be tested because they've been vaccinated, or just there's lower circulating levels of COVID around that don't need testing. So something to continue to keep our eye on, but it goes along with our cases right now. Similarly, our test positivity continues to decline and has for about 6 weeks now. Test positivity this week is 1.25%. Last week it was 1.6%. And test positivity by age group is relatively stable across all age groups. There's a little bumpiness decline in this 15 to 19 group, and they're flat again. So everyone's pretty stable over the last couple of weeks. So now we're going to look at the daily case, the number of daily cases. They continue to trend lower. So as you can see for this graph, the 7-day rate declined to about 640 cases per day currently. The 14-day incidence rate continues to decline, and it's now 12.8 per 100,000. That's awesome. Like, we really would like that to be under 10. And we're close to that level. And the state just, again delayed my the posting the metrics, but when we look at it by age group, we're seeing that same bell-shaped curve with the 15 to 19-year-olds having the highest rate. However, that 20 to 29-year-olds are no longer the second, in second place, if you will. We have the 10 to 14s, and the 5 to 9s are now holding the second and third spot. So when we talk about who's susceptible to disease right now, we're talking about the unvaccinated groups, and those vaccinated groups 20 plus have really had some strong reductions in their 2-week rates. So when we track it over time, that's when we'll see which direction we're going. So here I've separated the graphs into, the left is the age groups not eligible, currently eligible for vaccine. And on the right are the groups that are 20 plus, so eligible for vaccine. And oops, all right. Got a little excited there. All right, so so when we look at this graph of those who are eligible for vaccination, you can see that there's some really steep declines happening, especially in this 20 to 29 group who became eligible for vaccine about 6 weeks ago. There's 6 weeks to 4 weeks ago. The 15 to 19-year-olds are a little bit slower right now, but they, again, just became eligible for vaccination for the large part, and their vaccination rates are around 32%. All of the other age groups, 20 and above, have at least 50% had a first dose. And we're talking 75 plus have like 88% have had or at least one dose. So these groups are highly vaccinated in the state of Massachusetts, which is really great to see. And actually, if you compare 6 weeks ago to now, there's been a 50% decline in the number of cases among all these age groups averaged together. So if we look at the graph on the left, which is the 0 to 14 age groups, the good news is that these age groups mirror all the other age groups. So the vaccinated age groups who are protective and their rates are driving things down, they used to be the ones with the highest rates of COVID. So when we reduce the amount of COVID circulating, we're also protecting groups who are not vaccinated. So that's a good sign that these trends are mirroring the other ones. But if you look closely, 5 to 9, those in ages 5 to 9 and 10 to 14, the rate of decline in the last 2 weeks is really flattened. And this is kind of like what we saw over February break, is we had this flattening out for a couple of weeks, and then it started to go back up. And that's what we don't want to happen with these age groups. So we're hoping of like this last 3 weeks where it's kind of flattened out, that this will start to go back down again as more people in the older age groups get vaccinated, and we'll get to more vaccinations later too. So the other thing, the rate of decline in the 0 to 4 group was social patterns. They're not in school. They might have daycare, whatnot, but they're more tied to these older age groups. They're more closely bonded, if you will. They have more activities closer to an adult. So that is trending down a little bit steeper, mimicking the household trend, if you will. So we're hoping that these age groups that aren't eligible for vaccination don't start to climb back up over the next few weeks. We want them to stay this way or lower. The good news is when we go back to those serious outcomes for COVID, these two lagging indicators, hospitalizations and death, the hospitalization rate continues to decline. We're now about 430 patients in the hospital each day. And the hospital capacity still looks good. It remains at 86% of hospital beds being occupied. It hasn't changed over weeks now. So that system is not under stress, which is awesome. And then the 7-day average of confirmed deaths remains low, and with a daily average of 7 deaths per day. And yesterday was the first day since last June that we had 0 deaths reported. And unfortunately, I saw today that we had 1. But again, the level of deaths that are happening due to COVID this decline is fantastic. And it really shows you the power of vaccinations to protect against those severe outcomes. So the other thing, the state of Massachusetts, like I said, has this really robust vaccination program happening. And the state set a goal months ago to have 4.1 million residents fully vaccinated by early June. And over the past weekend, we hit 4 million people having received at least 1 COVID vaccine dose. So that's about 58% of all residents. So we're on target for meeting that 4.1 million resident goal. And yesterday we tipped over 3 million patients, or 43% who are not patients, 3 million residents who are fully vaccinated, with about 43% of all residents in Massachusetts. So these are really great numbers. And we're steadily moving to more people being into that fully vaccinated bucket. Okay, so let's look at the local data. So this next 3 slides are from the report, the DPH report from last week. So this is last week, Littleton had 30 cases reported between April 18th and May 1st, that 2-week period. We were still in the red. And when we compared it to the 2 weeks prior to that, there was 18. So last week we had a bump up back in, but when you look across, we were kind of just stable in that 28 to 32 cases for 4 out of the 5 weeks period here. So then when we start comparing Littleton's metrics to our surrounding area in the state and the county level, our average daily incidence rate per 100,000 for that 14-day period was 22, which was actually double the number of towns around us. So essentially, our rate had stayed steady for like 5 weeks, and everywhere else has trended down, including the state. We were higher than everyone. Our trend looked different. And then when the same thing was happening with test positivity, they were doing the same thing. So the number of tests conducted in our town were stable. It wasn't a difference with the number of tests. Our test positivity was 2.32% last week. Sorry, 2.88% last week, which was higher than the 2 weeks prior to that. And again, we were like pretty much, if you consider the last 5 weeks, we were just pretty much been flat where everyone else had been trending lower. So to summarize, our Littleton COVID metrics as of last Thursday's DPH report had been trending differently than the areas that surround us. That's why we asked Jim, why can you help us try to understand what's happening? Why are those exposures? What are those exposures? Is there any way we can like educate and inform people about why this is happening here? So Jim just gave us the count for this next 2-week period. So April 25th to May 8th, or I might have gotten that wrong myself, Jim. I don't remember. It ended May 8th, the 2-week period ending May 8th. So here's last week we were at 29, and this week we are at 16. So we had a large drop down for that 2-week period, which is great. We've had this singular week drop down and pop back up though. So 1 week does not make a trend. We need to see what's going to happen over the next 2 to 3 weeks to understand if we're actually going down or if we are going to end up back up and stable again. but this is a nice sign to see. We're back in the yellow. Okay, so the reason why I'm saying we definitely need to take a few weeks and see where we are in the next couple of weeks is because one of the hints that we have of what's happening in our town is to look at the health notification letters from the schools. And as of yesterday, so Monday and Tuesday, we received notification of 4 cases at the Littleton school systems. The good news is this wasn't through pooled testing, so this wasn't catching people who were in the school sick. These all came through the symptomatic and exposure notification system. So these kids didn't enter the school, basically. They might have been in the school, there might have been close contacts, but their parents were on top of it, and that layer of mitigation of like catching it early and telling the schools was working. So that's a good sign. One thing to note, I talked to Lynn Snow at the school today, and she said that they're working on putting a dashboard on the website, and they're currently working on populating it. So in the next week or so, it should be ready for public to look at any point in time that they want. So this will be easier to view, hopefully, going forward on a regular basis. So when we talk about those 4 cases that were reported this week, they've actually been spread throughout 3 of the schools. So there's been 1 at Shaker Lane, 2 at Russell Street, and 1 at the middle school. So now let's talk about who's susceptible. These are the age groups that are not eligible for vaccination. So I know that there have been a number of high school kids or kids in that age group that have been vaccinated in our town. So it sounds like a large proportion of our high schools are vaccinated, which will help their transmission to keep it low and hopefully not have many cases there. And so it's not surprising we're finding cases among the unvaccinated students, those age groups. Something to keep an eye on. We'll see. I know that Lynn Snow at the schools she's a numbers person, so she's got her eyes laser focused on whether these are happening among in-school transmissions or she tracks metrics. Her spreadsheet's amazing. So from what she's described. So I know she's on it and keeping an eye on it.
Katrina, sorry, could the high school vaccinations also be because the colleges are requesting them for in-person in the fall?
I think there were some very highly motivated seniors who wanted to be able to enjoy the end of their school year. So when they became eligible, they got vaccinated, as well as high school students were just like, I'm sick of always having to be and not being able to see my friends and always being that age group that was scapegoated, if you will. So I think a lot of them were just self-motivated to do that. There are a number whose colleges are going to require them to be vaccinated. So they just got on it early so they could enjoy the end of the school year and their summer too. Okay, so this is the vaccination data for each municipality from the state. This was from last Thursday's report. So this week we should have better numbers. But Littleton has done a great job with our vaccinations. So if you look at our all of the towns around us, Littleton's among the highest vaccination rates for all of those towns. So we have about 65% of our residents who have had at least 1 dose, and 44% of those residents are fully vaccinated. And the vaccinations are pretty high across all age groups, which is awesome. And the good news this week is that the FDA authorized Pfizer for ages 12 to 15. And then today, the advisory group for the CDC also recommended that the vaccine be used for this age group as well. So as of tomorrow, individuals 12 to 15 in Massachusetts can seek vaccination. So hopefully this 0 to 19 age group will quickly have more people in it that become vaccinated over the coming weeks. Men still lag behind women in terms of the number of vaccinations. However, they've had a bigger growth than women did this week, which was nice to see. I think it's important to note that males have a higher risk of severe disease and death than women do once they're infected with COVID. So getting men to vaccinate is a good idea, just as much as everyone. But given that they have a higher risk of severe outcomes, this is a good group to target. So the other thing that we have to keep talking about, the CDC released their updated variant data, and the B117, that UK variant continues to be the most prevalent lineage in Massachusetts. It's about 50% compared to about 44% 2 weeks ago. Massachusetts also has one of the largest proportions of circulating P1 variant. That's the one that was identified in Brazil at 10.6% compared to 7% 2 weeks ago. So that is also growing. The good news is that the B1429 and B1427, those two out of California, have actually still 2% of our sequenced variants are those, and they're actually stable compared to 2 weeks ago. So those don't seem to be growing at the moment. The other thing to note is that the CDC added the B1617 variant. That's the one that's being looked at in India. So that's now present in the US. Excuse me. Present in the US, but there are less than 10 sequenced viruses that were that. So they don't have really good numbers on that right now, but it's here. The thing that's being, I think everyone's heard about what's happening in India. The UK and the WHO have all upgraded it to a variant of concern because of its transmissibility, and they're not sure about disease severity. The UK actually have seen some data on theirs, and they are concerned in watching it because it's having a growth curve much like B117 did last fall. So people are really trying to watch this and make sure that it doesn't take over as the new variant in the UK. People are still trying to figure out if our vaccines are well matched to this variant or not. But they did see some hopeful news that with some data about hospital workers at two of the most major hit hospitals in India, that it was really protecting the healthcare workers. So more work needs to be done to make sure that this variant doesn't escape our vaccines. But right now, the indications are hopeful that our vaccines will continue to work against this variant, the India variant. So I want to return to this idea of community immunity, but really targeted into Littleton. So to date, Littleton has had just under 600 cases identified in our town. That's about 6% of our residents. So we had a lower proportion of our residents in our town compared to the 10% of the state. So we did a really good job keeping it contained during this, compared to other areas of our state. Littleton also has high vaccination rates. So 65% of our residents have received at least one dose. So these are going to help prevent new outbreaks once we can get our cases back down lower. You can't add these two numbers together. So I can't do 65% plus 6% and say that we're over 70% covered with immunity, because there's some overlap between people who are sick and people who got vaccinated. So we just know that they're here, and we still have at the bottom is 65% of people have some sort of immunity, which is still amazing. So as Massachusetts continues to reopen and roll back COVID policies and relax masking orders and things like that, the more things that open, the more COVID will spread. And it will spread most likely most quickly among unvaccinated individuals. So as we think about our vaccination coverage in town, we've got to remember that there are those pockets of unvaccinated people who socialize and mix together. So we're talking the kids in the schools who are not vaccinated, especially the elementary schools, or those who have health concerns and therefore can't get vaccinated. So those people still are out here in our town. There are people who are choosing not to get vaccinated for various reasons, whether it's just hesitant, they want to see more data, or more people they know get vaccinated before they also get vaccinated, or for more stronger or political reasons. There's a wide range of reasons why people would choose not to get vaccinated. So it's, and those reasons tend to cluster. So we have, if a parent chose not to get vaccinated, they're less likely to have their children vaccinated when they're eligible. It's friend groups tend to look alike and think alike. So those are the groups that you'll find clusters within friend groups and things like that, or activities. Certain activities will have a higher proportion of people who think alike and therefore may not be vaccinated or may be vaccinated depending on the activity. So the concern is with these more transmissible variants, it's easier once COVID gets in those unvaccinated pockets for it to spread quickly. So it's really important as we go through, and if you talk to people, try to share your vaccine experience, things like that, to help convince people to jump into the vaccinated pool to help protect everyone. Another group who it's coming out that people don't think that they need to get vaccinated is actually people who had COVID and recovered. It's still recommended that these people get vaccinated. So your body should produce antibodies following a natural infection. So you should have some sort of protection against future infection. However, studies have shown that individual antibody levels following natural infection are highly variable, and they're not as strong as they are with vaccine. So vaccines really provide a stronger and more consistent antibody response compared to natural infection. So that is a reason why, especially given circulating variants that somewhat reduce the effect of the vaccine, why we would recommend that everyone, even if you had COVID and once you've recovered, then you go seek vaccination, because these vaccines are really well matched for the current circulating variants, especially in our state. So the big news, like I mentioned earlier, is that the FDA authorized the Pfizer vaccine for children aged 12 to 15. And today, the CDC advisory group they voted to recommend the use of this vaccine in this age group as well. So these are actually some of the slides from today's ACIP presentation for the CDC. The clinical trials indicated that the most common side effects, and as a parent, I hear people are more concerned about side effects. What's going to happen to my kid? What are they going to have? So I'm running through the side effects right now. So the most common side effects included common vaccine-related side effects. So injection site pain, fatigue, headache, chills, muscle pains, and fever. And the safety results were actually very similar to adults aged 16, well, people aged 16 to 25. So they compared those two side to side. And the purport, like the amount of these vaccine-related side effects were similar for those age groups too. So that's a really great development. Kids in this age group, the 12 to 15 age group, actually had higher antibody response compared to the 16 to 25-year-old group. So if your kid gets vaccinated, they actually have even higher response at preventing or building those antibodies. And remember that these vaccines are really good at protecting from not only severe disease for this age group, but also spread among this age group and others. So one thing I've heard a couple times is that it's not a big deal. My kid is not at high risk for severe disease. They don't need to be vaccinated. And actually, from my public health point of view, COVID among adolescents is a public health problem. So it's about 19% of COVID cases, once we adjusted for some underreporting, have been among this age group, this adolescent age group. And adolescents also have a highest rate of infection and symptomatic spread compared to adults and children. So this 12 to 19 age group is like the most active in transmission. They contribute to spread. Transmission is higher in those middle school and, like we just talked about, middle school and high school age groups. So compared to those elementary school groups. So vaccinations are important to help support continuing in-person school for these groups. And although, which let's be honest, school is like one of the most important things we can give these kids. So we want to give them a fighting chance to be able to stay in school. And although the number of deaths in this age group is low, COVID-19 actually ranks among the top 10 causes of death for this age group. And then to date, there's been nearly 4,000 cases of the multi-inflammatory syndrome, the MIS-C, of which 21% are adolescents in this 12 to 15 age group. And the severity of this is actually worse for these older age groups than a younger group. So while it's not frequent, when somebody has it, they have a worse outcome. And kids in this age group that have been hospitalized includes kids who are obese, who have asthma, who have other health conditions. So I think everyone knows somebody who has, especially asthma or obesity or, you know, some health condition that among their friend group. So we want to protect our friends. So getting vaccinated would be one way to help protect our friends from severe outcomes. So that given that these kids aged 12 to 15 are currently among these age groups with the highest transmission in our state, and that this group is highly social and they're mobile, vaccinating this age group is a great way to get them back to their normal social lives, you know, getting them back to normal, helping their mental health that way, to keep these kids in school and to protect not only them, but their families from long-term health effects from COVID. And so if you have any questions about the vaccines for your child, I really encourage you to reach out to your child's doctor to ask them. I did that today with my daughter's doctor, and I had a great conversation. So I highly recommend everyone do the same thing. And I think this is my last slide. So vaccine supply is no longer an issue. It's easier than ever to find a COVID vaccine in multiple close to home area places. So we got the state's mass vaccination sites, CVS, Walgreens, Neshoba's Associated Board of Health vaccination site that we just talked about earlier tonight. Lowell General Hospital, all of these places you can schedule an appointment to get a vaccine, and you can also do walk-ins at this point. So it's becoming easier than ever to go get a vaccine. It's not like staying up at midnight to make your appointment anymore like it was a month ago. At this point, you can access a vaccine if you choose to. And I know that Lowell General has Pfizer, and they were accepting appointments for the Pfizer vaccine for the 12 to 19 or 12 to 16 age group, 17, those age groups that only can have Pfizer. Lowell General was taking appointments. That's actually where I got my daughter an appointment for a couple of weeks from now. And CVS just opened up their registrations locally. I don't think it will be at Littleton CVS. It doesn't sound like that, but it is in other area CVSs around us for those who need the Pfizer. But Littleton is also giving Moderna vaccines here in town. So there's lots of options for people to get vaccinated at this point in time. So please consider seeking them out and just keep talking to your friends. So one of the best ways to convince people to get vaccinated, people are more comfortable learning and hearing about their friends' experiences. So the more people can keep talking about their experiences and encouraging their friends to get vaccinated, the safer we will all be in the end. That's it.
Great, thanks, Katrina. Do you, does Mike or Jim or Katrina, do you know anything about the boosters and like first healthcare providers were vaccinated back in January, so that's almost 6 months from now, or 6 months been gone by. So is there talk about that at all, or are we still waiting and watching?
So it's my understanding that Pfizer and Moderna have both been developing, and J&J have both been developing boosters, or J&J is looking at what would happen with a second dose for theirs. I know that Pfizer and Moderna are looking at boosters. They actually just talked about it today at the state's, the governor's press conference. So with anticipation that with the variants and things, people might need a booster. People are doing the research now, but I'm not sure we're at a point where they're worried about waning immunity or the variants not being matched to start needing boosters yet. So that's information to come in the future, but the research is being done now so that if and when we need them, we will have the information we need in order to proceed quickly.
The only information I have, which is fragmentary, is on the question of the, I'll call it the longevity. How long does this, shall we say, a fully vaccinated person, how long is that protection? What's the serological titer, let's say 6 months, 8 months, 12 months, 14 months following? And at the moment, surprisingly, not surprisingly, given the fact that we're still sort of in this, the only data, and it's a very small sample, actually comes, I believe, from Moderna. And there's fairly good confidence for 6 months. But after that, I don't know of any completed study yet that I could cite that says, okay, we're good for 8 months, 12 months, whatever. This is just basically the question that's being addressed is how robust and how much of a response remains after X period of time following full vaccination.
Pfizer had a similar study recently too, Mike, that they were also, so they had followed people for 6 months, so they can say at least 6 months.
Right.
And they'll keep following them, and they'll say 9 months or a year after that, depending on what they find.
So it was the 6 months finding that stimulated everybody to start looking at, quote, boosters, because obviously, given the techniques involved, at least for Pfizer and Moderna, they more than likely could turn it around rather fast to not just extend protection, but also respond very quickly at the same time to variants if necessary. So it all makes sense. So it's something that we should keep our we should track that if we can, with maybe even making sure that we're following little blurbs from the CDC from time to time.
Okay. Does anybody have any questions for Katrina? No. All right. All right, great. Thanks, Katrina. All right, so Kevin, I was looking down. Did you have something you wanted to say, Kevin? Dan? No. Okay. All right, so thank you.
Gino just had his hand raised.
Oh, okay. Hi, Gino.
Sorry, somebody put me off. How
Yeah,
long will it take?
because you're chomping on your dinner, Gino.
Well, you know what I mean. I'm pre-meeting this today, okay? I mean, I gotta eat sometime, and then my wife says, "Oh, you gotta do this, go to do that." How many more people has to be vaccinated completely from Massachusetts? How long it will take?
How many more? So we have about 6.9 million people in Massachusetts, and if we're
Right?
Yeah, we're like halfway there. A little more than halfway. We're like 60% of the way there.
Would you say about 6 months, maybe?
Well, I think we're not going to get the age groups that are 11 or younger. They're not eligible yet. So that's a 15% of our population. Those aren't going to be eligible until maybe the end of this calendar year at the earliest, or at least 5 to 11. So I think the state is pretty confident they will get to, the original goal was 4.1 million in June for at least a first dose. So, by July, we're talking that's fully vaccinated. Hold on, I'll do a little math here. I can't do math today. So that's about 60% by the next month. And then if we're adding in the 12 to 15-year-old crew, we'll get another 5%, probably over the summer. I would expect some parents to wait a little bit just to see how it happens. Like, you're going to have the early adopters, and then you're going to have people struggling. And so hopefully by school year next year, a lot of people will have vaccinated their children in that age group. So maybe by fall, we'll get to hopefully 70%.
So in other words, we're going to be on Zoom for a little while longer.
I think it's getting better, Gino. I'm
You
hoping
think so?
I can see you every other week.
And I will be able to see my friends, even though they don't like me anymore. So I can be able to go to a meeting, face to face. So
We don't have, there's no room. We already found out there's no room for us at town hall yet, Gino.
So I can eat home without being criticized when I'm chewing something because I'm hungry. I mean, what happened for those people that don't like to be vaccinated? What happened?
There'll be a group who just don't. And hopefully there'll be enough people who do that we can help protect them too.
Well, I really appreciate what you're doing, okay? You give us really the up. And Jim, I really appreciate what you're doing for us, and you take time off just to be with us. I'm so sorry that you have to do that. Nevertheless, you got to do it now because we're going to miss you for a long, long time.
Jim, I was thinking today that if you had a vaccine clinic at a Dunkin' Donuts, you'd probably get a lot of people.
There you go. But would they wait in line for their coffee and a vaccine? I don't know.
Yeah,
The first
coffee and
one-
vaccine.
There are states that are offering beer with after your vaccine, and it's working. So you never know; it'll work.
One of the states has a program called a beer and a shot or something
Yeah.
like that.
It's like, why isn't it a shot for a shot? But okay, marketing needs work.
All right, thank you very much. So
Nice
let's
to see you all. Nice to see you all. Congratulations, Dan. Congratulations, Kevin.
all right, we're not done yet, Gino. We're
Oh,
moving.
you got more?
Oh yeah, we got a big night tonight.
What about my dessert? I won't be able to eat my dessert now. All right.
Just turn your camera off and mute yourself and have your meal.
No.
All right.
I like to see your faces a little bit.
So next we're going to have a discussion with the Department of Public Health with Michael Hugo and Cheryl Sparrow, but I think looks like Michael is the only one here tonight. So Michael, if you can, I guess maybe Kevin too, since you invited these folks, see what's up.
Sure. So Mr. Hugo is the Director of Government Affairs at the Massachusetts Association of Health Boards. And we've been speaking throughout this whole pandemic regarding some contact tracing efforts with Kevin Davis. And I clued Mr. Hugo into sort of the direction we were thinking we were going to be going in. And I think he'll have some good insight, different frameworks and things we can do to not recreate the wheel, so to speak.
Well, actually, I guess I forgot during the COVID update to ask Kevin Davis if there was anything more than that he wanted to say. Sorry. Anything quick you can add, Kevin? Kevin's hands up.
Yep. Hi. So nothing major to add as far as the contact tracing. I would like to add to what Jim Gareffi said earlier. If there was only some other way that we could possibly do or enhance contact tracing, this would be the perfect opportunity to aid and assist that effort to try to figure out who was near who and all that kind of good stuff. The state, the Mass Notify is the app that they're working on. The state is still in the pilot sequence, and I have no other data or when they're going to go out of the pilot and just turn on the key. I would love to see this happen because then we can start again, as you know, doing the sales job to have people turn that on. This will be great to also assist those age groups that Katrina talked about that are so important. The sixth graders all the way up through the 20 somethings that always have a mobile device in their hands or on their body. This will greatly help with some of that contact tracing. So that's all I got.
All right. Thanks, Kevin. Thanks for sticking around. Okay. All right. Sorry, Mike, Kevin or Mike, are you a little segue? Are you in? Are you done, Kevin?
Okay. Hi. How is everybody here? First of all, I want to say that I go to a lot of these meetings, and Katrina, what you just presented was stellar. It really was.
Lucky.
You're extremely lucky. I've seen everybody from people who said, "Gee, I don't know," to the best of the best, and you're right up there with the best of the best. That was a fabulous presentation. You guys are very lucky to have her.
And she's ours.
Yes. So with that said, I'm not 100% sure what it is that I can talk to you about tonight. I know that Kevin had told me that your health department is treated as a second-class citizen, I think, by your town right now, and that he's hoping that we might be able to increase budgets and to increase your personnel. I'm not sure what the picture is there. I know that you're part of the Neshoba group, and I know that the Neshoba group is doing its thing, and as part of it, you're getting your services there. So I'm not 100% sure, and maybe Kevin, you can just give me a little kickstart here and tell me exactly where you want me to go.
I don't think the word second-class citizen ever came out of my mouth.
No, and it didn't, and I probably should not have said it that way.
So we have been, and Mr. Zeldin can probably chime into this as well, but we've been over the course of the last maybe 3 to 6 months trying to determine sort of the next phase in the public health world of the town of Littleton, being that we're growing and the need for services is greater, and trying to formulate a framework of what this sort of Department of Public Health looks like and what resources are out there for the town of Littleton to take advantage of, basically, to move forward and, align ourselves with the right folks, hire the right people, develop the right systems, and put together a cohesive Department of Public Health that can really help protect the public health of the residents of Littleton to the best of our ability.
Okay, so at this point, really, it's a question of what kind of staffing you have right now and what kind of staffing you need to get to.
Excuse me, could I just add something to what
Sure.
Kevin said, just so
Please, Mike.
that the other mic, as it were, can plunge in. You're quite right that basically our major on the ground public health service has been coming primarily from Neshoba, and there's another pieces of it that reside in the Council on Aging. In other words, as in most towns in Massachusetts, it's highly fragmented. Number one. In other words, public health services are all over the map. But I have to say that the Neshoba group has, in terms of staff and professional know-how for public health, I'm leaving out septic systems and all the rest, glorious as they may be. There are other things, as COVID has revealed. The second thing is that in 2000, I'm just echoing, in 2019, the state released a large panel, sat down, investigated, came up with basically a report that said not only is public health in Massachusetts highly fragmented, but also we don't know really what's going on. In other words, data collection, facts on the ground are missing. Littleton is another instance of that. It's just, highly granular data is not available to us, that we would need to say even what are the 3 biggest problems in Littleton? Hard to answer that question. So given the environment, and also I would point out the state encourages collaboration, not having individual health departments going off on their own. They look on the current system as collaborations and extensions of the state's public health system. In fact, there's definite rules decide just how far we can and cannot go. We don't need to go into that, except in general terms. So there's a number of things here about the wisdom of moving forward on our own, that is having our own health department. What are the triggers for it? What should be looked at? And what are the trade-offs, very frankly, once you make that cross the Rubicon?
Okay, so right now, and Mike, I think you picked up on a lot of different areas in that short statement. First of all, the Special Commission on Local Public Health, which is the panel that you're talking about, and I'm sorry, Cheryl couldn't be here tonight. She had to actually do a different meeting, and so we had to sort of divide up tonight. But Cheryl was part of that special commission, and a very active part. She actually probably did more writing of the blueprint, which is their final report, than anyone else. And I'm hoping that you all know who she is, and you've met her before, I'm hoping. But the blueprint really lays out a path forward for public health. We are the only state. I go to the National Association of Local Boards of Health, to NALBO, and I'm the Massachusetts delegate to NALBO. And almost every single meeting I'm at, somebody in the room turns and looks at me and says, "Hey, Mike, get up and tell us about Massachusetts again. That's the funniest thing we've ever heard in our lives." And I start out, well, we have 351 separate boards of health, most of whom are working completely in a vacuum. We have so many districts and so many cities and towns in those districts. But it blows everybody's mind that we have 351 boards. And so the blueprint that came out of the special commission calls for really workforce standards. And it kind of seems like right now Littleton is kind of almost going against the tide, because you're looking to narrow and strengthen your own Board of Health and your own health department at a time when not just the State Department of Public Health, but loads of other, in fact, 192 other municipalities in Massachusetts just qualified under the grant program. And I think you're familiar, hope you are, but I'll tell you in one or two sentences. Mysteriously this year, all of a sudden, we had a $10 million line item in the Senate budget for the first time ever to get local public health funded by the state to a certain degree. I got my state senator, and I live in Framingham, and my state senator is the Senate president, with whom I have a 20-year personal friendship, and it's usually grounded in me starting every conversation with her about how bad off we have it in public health. And so one day, a couple months ago, I got a ding on my phone, and I looked at it, and I had a text message from Karen Spilka saying, check line such and such of the Senate budget, you're going to love me. And I checked it, and she stuck in a $10 million line item, which we'd never seen before. So that line item was turned over, that $10 million, plus actually it's another 1.7 for the SAFE program, which is the State Action for Public Health Excellence. They were kind of melded together, and DPH came up with a grant program to give out 30 grants for up to $300,000 apiece to cities and towns that would combine their services, which is why I'm saying you're kind of going against the tide, because you're trying to declare independence at the time when everyone else is trying to reach out and work with other groups. So there were 30 applications. One was refused because it just didn't have anything to do with public health, core public health functions. So one didn't make it out of the 30 applications for $300,000. And they actually ended up with a little extra money. And this might be of interest to you. This is one of the things I wanted to talk to you about, and I had mentioned to Kevin. Not everybody applied for the $300,000. Some people applied for $50,000. So they ended up with distributing $7.7 million out of the original 10. So they have money left over. They're going to open it up for a new round of bids, which will happen, I think it's going to be aimed at starting in the next fiscal year. The first round of bids was really weird. Jim, I know Jim did one of these also. I did one for Martha's Vineyard and Nantucket as their grant manager. Basically, we helped them at the Mass Association of Health Boards. We helped them do their grant, and what we did down there was we were hiring an inspector, a biologist, because they have a huge tick problem on both of the islands that affects their public health in a horrible way. And we're hiring a I'll say a population health worker. You can't say community health worker. That's a different certification. But somebody to help with the fact that they have 1 in 5 of the people that live on those two islands have substance use disorders, which is huge. So we're going to try to address that, and teen suicide is out of control on both of those islands, and especially now with COVID and kids not having any socialization. So they're going through some horrible stuff. So the state gave us a grant for that. I know that they gave your neighbors. I'm trying to think if it was Carlisle is with Sudbury, and I'm trying. It's one of the. I'll tell you right now. It's not. It is one town over. Oh, never mind. I just shut the map in front of me. But it's one town over from you. Has one for trying to achieve certification. The national accreditation for 3 or 4 towns working together. So that's these grants are given for that sort of stuff. Now, the fact that there's going to be more grant money should be of interest to you, but you can't participate in more than one grant. And we're going through that right now with a town in the southwestern corner of the state that found itself in two different grant bids, one with the Berkshire Collaborative, and one that they were in with another group of towns. And so that's actually the town of Alfred. And everybody's trying to figure out what to do with Alfred. You guys are part of that right now with Neshoba. So if you were to go for your own grant, you'd have to see seed from the Neshoba grant, which I'm not sure what that does to you. I don't know how that works with, with your overall plan for the health department. But you're part of Neshoba. They have been given. Jim, what was your grant for?
We were looking to hire an inspector, a community educator, and a part-time food inspector, plus get food inspection software and devices to be able to do that.
Okay, so that's really a great step in the right direction. So the issue is really what you want to do. If you feel as though you want more autonomy, again, it's kind of a funky time to be doing that right now because everyone else is going the other way. But if that's what you wanted, there are towns in your area that I'm sure that you could bid the next round of grants with, and see what you can attract for yourselves. I just don't know that it's going to be, where everything is heading towards regionalization without using that word. Regionalization in Massachusetts is a terrible word. I appeared in front of the Board of Health for the town of Aquina, and Aquina has a secretary that works in the office because the health director got up and walked out over a year ago, and they have never replaced it. Their secretary works 18 hours a week, and they're totally happy with their situation. And I appeared before their board to tell them that we were bidding this grant. And I never even got beyond introducing myself with my name before the chair of the board started literally screaming at me. You're not coming in here and telling us how to do our business. We've existed for all these years. We don't need you and your government to come here and tell us what to do. And it was like, oh my God, the amount, that $300,000 is more than their all of their boards of health have all put together. Yeah. And it was awful. But they have now everybody's voted to go with it. But the point is that you need to really define for yourselves what you want to do. We can help you the same way that we're working with the group in Alfred and the group with Nantucket and Martha's Vineyard together. We can help you do that and come up with some strategies if that's what you want. But it really has to be what you want. You have to be aware of the fact that unless we can attract at least 2 other towns, because you need 3 towns to do it, and I'm sure we could if in the next round. But I'm not sure that you want to go that way. I don't know that you. I don't know what your staffing is right now. It sounds like Jim has his arms around the staffing pretty well. And so it's not like, we do have some towns that come to us and they say, help us, we have nothing. And when you go there, they literally have nothing. They don't even have an office in town hall, some of them. So, it's really up to you guys. And we can help you do whatever it is you want to do. We can help you formulate a strategy. But we really need to know exactly what it is that you're looking for us to help you with.
Yeah, I think the major thing for the impetus that pushed it in the direction of looking at, as you put it, autonomy. I think what really pushed it was the fact that for whatever reason, during the period of time that Littleton has been a part of the Neshoba group, there has been a kind of, I will call it until this year, a disconnection between our, as far as I can make out, looking backwards in time. All right. There was sort of like a bubble inside Littleton, and no one asked questions. No one. Basically, I'll put it this way: I don't think that the Neshoba group was, shall we say, exercised in a suitable manner. And I think that very recently, thanks to in part COVID, thanks in part to activity of other members of this board, and thanks a lot to Jim, I believe the connection between Littleton and the association is now becoming more real, at least from my point of view. Okay. And I think that there's a lot more to be gained, very frankly, from taking an even-handed look at continuing with Neshoba, because there's not only a history, but there's institutional knowledge. And more frankly, it could be, frankly, more cost effective. I think what probably we should be spending more time on is understanding more clearly what are the public health needs of Littleton. What serves the people the most and the best, and then, as it were, quickly or as efficiently as possible, try to come to a decision or a choice. What are the advantages of semi-autonomy, complete autonomy, but more significantly staying, as it were, and continuing to improve the relationship and working relationship we have with Neshoba?
We have metrics. One of the kind of cool things about MAHB with COVID, and COVID really changed the world. In many ways, it was a tragedy. It was definitely a tragedy, but in many ways, COVID has helped public health. Number one, people know what we are, and the reason, when during my 14 years on the Board of Health in Framingham and my 8 years as chair, going to this town meeting every year, begging for anything we could get from town meeting. I had to begin my speeches by saying, you don't even know what the Board of Health is because we're doing our job. And it's not until the stuff hits the fan that anybody really needs to know what a Board of Health does and what we're there, what our strengths and weaknesses are. So, we're kind of a silent, it's kind of like being a submarine. People know you're there, but they don't know what you do, really. And so that's an issue of respect from your town as far as getting budgets and manpower over and above. It may be that Neshoba has what you need. It may be that Neshoba comes close to what you have. But one of the and in that case, there may be something we can do to help you fill in some blanks. But one of the things that one of the benefits we have is that we've done some metrics. And MAHB has a staff actually of epidemiologists, because our president, Marcia Testa, is at Harvard School of Public Health, and she is the director of the emergency prep program there. So she has a whole bunch of epidemiologists. So we have some pretty good ideas numbers wise. Like, you tell us how many restaurants and how many people you have in your town, we could tell you how many inspectors you need, and we could tell you how much nursing help you need over and above what you have. We can give you hints on how to recruit other people, other nurses in town to work part-time as public health nurses. In Framingham, Sam Wong, who was our director at that time, noticed that we're going to have to be doing a whole lot of contact tracing, and at the same exact time that was all emerging, the schools closed, and we have 27 school nurses in Framingham, and they're on the payroll. So Sam said, if you're getting paid, come to work for the Department of Public Health, and we will put you to work doing contact tracing. And that's how Framingham did its contact tracing. So there's ways of rolling across programs and things of that sort to fill in. And so we can help you as far as determining what your base needs are. And then you can go to Jim and you could say to Jim, we need a little bit more attention here, and we don't need so much attention there. Everybody needs community health. Especially now, with all of the shut-in issues, and in the very beginning, if you all think back to the very beginning of COVID, one of the biggest fears we had in the world of public health is that you have a lot of domestic violence, and you're now putting the victim, you're locking the victim down with the threat. And that was a real issue, and it still is a real issue, and it's affected people psychiatrically, psychologically, and sociologically in every way, shape, and manner. The kids, I learned from one of the boards of health that I was talking to that one of the boards of health members has a granddaughter who is in the hospital with a feeding tube because the kid stopped eating because she hasn't seen her friends, and she went into a deep depression, and they're treating for life-threatening anorexia right now, and so it affects everybody. It's every one of us. It's just like the addiction issue. You know, there's nobody that doesn't know somebody who has had an addiction issue either in their family or a close friend. There's just nobody anymore. So we can help to determine what your metrics would be, and you can say we're well served here, we're not well served there. Jim has, he's put in the grant for exactly the most classic core functions, and Jim's been in a lot of those meetings that I've been in where we've heard that if you don't give us core functions, we're not giving you money. And those are classic core functions that he put in for. And I think when those hires are made over the next couple of weeks, you're going to find that there's, or over the next month or so, you're going to find it's going to change your level of services. So you should probably keep an eye on, keep your mind wide open right now, and see how it works with the new staffing. I think that the budget, the way the budget was, there was $50,000 that you could get before the grant program starts, because it's annualized, so we could get 2 months worth. I took $50,000 for the islands, and I'm buying a bunch of computers and a bunch of software with that, so that when we make the hires, we have the infrastructure to plug those hires into. And Jim, I'm sure, is doing the same thing with his right now. He's gearing up, and I think you ought to ride it a little bit and see whether or not, once these new hires are made, whether that fills in your holes, and see where it goes. And if you need someone else, there's going to be more programs. There's so much money coming at us right now from the federal government, and some of that is going to trickle down to the local boards of health, and you'll be able to, perhaps, if you need something more than what Jim's agency is able to deliver to you, you'll be able to make that hire. It's such a fluid thing right now. There's so much money going everywhere.
The other piece of fluidity, sorry, and Kevin, if you want to come in and, I can understand it, but the other piece of fluidity is Littleton itself is going through basically, or had been going through a rather, I wouldn't say difficult, but very exciting growth phase. It's changing. The demographics are changing. Basically the population is changing. It's, as usual, housing is always controversial. Here it's really controversial, small town, all the rest. And I have to echo your comment, because that's what we're doing at the moment is exactly, we're not hanging tough. We're basically trying to do as much as possible to, as it were, make the situation with Neshoba work, shall we say, better. And that requires the town itself to step up, and as it were, make the connections, make the association really work for our town. And there's other things that we could do to, as it were, shall we say, do a better job delivering public health, especially if we have a well-defined direction. And here's where metrics do come in. So even though I'm just a member of the board, I can tell you I'll be chasing you down to try to understand how to get hands on some of those metrics.
Right.
Absolutely, and I'll say you have Katrina, and that's what I just saw is you guys have your arms pretty well around a lot of metrics right now that a lot of towns don't have. So, I just think just proceed slowly and cautiously and see what Jim's new pathway opens up. And there are going to be holes, because you just said it, Mike. Your town is changing, and it's growing, and that means that you're going to have people living in substandard housing. You're going to have people cramming in. Do you have any of that yet?
No, not yet. Not to the extent where it's. Well, I'm going to say no, but I don't think the town really measures it. I mean,
do you have homeless people?
Excuse me?
Do you have a homeless population at all?
I know that we do, but I would have to say it's nearly invisible. Right.
Okay. And you don't have the numbers.
The measurements. Right. But you have to understand that in order to answer those questions, there has to be a mechanism. There has to be something out there that's, shall we say, commissioned to find it, as it were, to define it, to measure it.
Mm-hmm.
And at the moment, I do have a suspicion we got rough measurements of certain kinds of issues. Probably mental health is one of them, except that's a big one. And which part of mental health? So it's shall we say, it's a work in progress. We've just started this. As I said, the Board of Health until very recently has been crickets. Quiet.
Yeah. Okay. Well, I would just, like I said, I'd see what Jim's new staffing does. You're probably going, I'm guessing right now, without any basis to guess this, but I'm going to go out on a limb and say you're probably going to need somebody to help you with your community health issues over and above what Neshoba can give you. So that might be something that you'll have to go to your town meeting and get some budget money for, and somebody to direct that person. And I think that Jim could probably direct your person if you don't have a health director in your town, which I don't think you do you?
Yes, Jim is, quote, our health
Right,
director.
right. But I mean, I'm saying like resident in your town hall. So you might need somebody, or Jim would direct that person. You could hire that person, and Jim would direct that person for you. I think that there's a lot of opportunity, and there's a lot of there's a lot of new excitement and new money in the air right now for a lot of this. So, and I'd be happy, Mike, and Kevin will tell you I'm pretty accessible. And for any of you, if anybody wants to talk to me about, helping you to attract some sort of a new, I'm always looking for grants. I scrape for grants. I every day I go out online and I look for different grants. And if there's something you need, I can just add you to my list. I feel like Santa Claus, but and if you're naughty or nice, we can give. I'll just throw you guys in my bag over my shoulder and find you somebody. So, but we can work on that. I think that you're a changing town, and it's a good thing. But with change and with adding population, you add some very difficult strains on public health, and let's be ready for that. We can help you be ready for that. And Jim, like I said, Jim is he's definitely a willing partner here. So
Great. So, Mr. Hugo, I think probably be a good idea to, might be a good idea to have you come back again and talk to us when we have a little bit more specifics.
Yes, and I will make sure I bring Cheryl with me.
Okay. Right.
And that's the other thing, though. You should know this is that that's not just a document, Mike, that you're talking about. The workforce standards. I attended the meeting yesterday, and there were 5 people that somehow I got roped into this thing with DPH to look at the workforce standards across the Commonwealth. And if we were to give Jim the database that they showed us yesterday, the Excel spreadsheet that they showed us yesterday, Jim would jump out the window. It was the most unworkable, ridiculous thing I've ever seen in my life. But then, and I made that point that these people don't have time for that right now. They don't have time to do their regular business, and they're not going to have time to do this ridiculous form. But what it highlighted was the fact that there's no uniform work standards right now across boards of health. I have 6 boards of health in Martha's Vineyard, 6 separate boards with 3 people on each board with 6 different health directors, and except for that secretary, and they don't talk to one another, and there's very little sharing going on. And so how do you work with that? And if you don't have the metrics, but how do you get the metrics if not through a database that you can't use? Nobody has time for that. But your inspectors are all going to have to be certified in like 8 things by the time they're done. You guys, the members of this Board of Health, are going to have to go through trainings as part of the blueprint. And if you haven't seen it, I'll send a copy of it to Kevin. He can pass it on to you guys. But the blueprint says that boards of health need certain minimum trainings. That's what right now I've got 10 halves of my life, but one half of my life right now I'm trying to work on the program between now and July 1st, where we're going to have 2 or 3 training programs for Board of Health members watch this space, because we're going to be sending you some notifications. And by the way, if you have agricultural work, and Jim, I don't know if you've seen this, but MAHB is going to be doing a program on May 27th on agriculture. There's a new statute that says that if you have an agricultural commission, you have to go to them before you can pass any health regulations to give them a chance to comment on it. We're going to be teaching that, but we're going to be teaching a whole bunch of different workforce development things over the next 2 months. We're going to have at least 2 or 3 sessions over the next 2 months, and then starting in the fall, we're probably going to have every 2 or 3 weeks a training. We're going to record them. You'll be able to watch them at your leisure. We can send you the test, and there'll be a test on it. You get a certification for it, because we're going to have to prove that we've been trained in certain things. So that's all coming. That's all coming to boards of health. It's coming to your inspectors. It's coming to your community health workers. It's coming to everybody, your nurses. Sorry, Katrina, but you're going to have to do one too. But everybody who's working with the Board of Health is going to have to go through these minimum trainings now. So that's there's a lot going on. A lot going on.
All right. Does anybody have any quick questions or comments for Mike before we move on? Because we've got a few more things on our agenda tonight. But I think that sounds great if we can, as a board, can kind of work on specific things, and Mike and Jim and Kevin, Gino and Dan, to get some things together for our next meeting.
Just let me know, and I'll make sure that I have Cheryl with me, because she can answer the stuff in her sleep.
Appreciate you being here.
Thanks.
Okay. Thank you so much for the invitation, and good luck to you guys.
Thanks, Mike.
All right, Mike. We'll see you. Bye-bye.
All right. So moving on to the discussion on mental health with Amy Tez. Thanks for waiting, Amy. Did you guys all get a chance to read Amy's presentation?
I did.
Okay, can you hear me okay now?
Yes.
Great. All right, I'm just going to share my screen really quickly and get my presentation up and running. Great. So I just want to say thank you for having me tonight. I know it's been a long meeting, so I will try to move through as quickly as possible here for you. So I'm going to be talking tonight about mental health, some statistics that I've been able to pull together, as well as some considerations for our community as we think a little bit about how mental health might be impacting us, particularly given pandemic effects. It's actually coincidentally Mental Health Awareness Month. I think it's a good time to be talking a little bit more about mental health and information around that. And one of the things I can say in the 20 years that I've been working in the field is that when it comes down to it, prevention and early intervention are really key to helping stem longer and more intense impacts of mental health issues for people. So right now, we have a lot of data that's coming out towards us. Mental health data tends to lag behind a year or two just because it's normally reported annually. So what we have is 2019 data that gives us a pre-COVID baseline. It'll be a really good comparison for us moving into the future as we start to learn more information about how people are faring. And what we have with the early COVID mental health data that's been gathered is self-report. So individuals like you or me who are just reporting how we're doing. We also have information about encounters. So providers, hospitals, people that are reporting how many people are being seen for whatever service that might be. And then we have national and state reporting. So through the Census Bureau and the CDC, they have a household pulse survey where they target questions towards mental health, and we have some information from that. And what we know about the pandemic impact right now is that, most people are reporting significant increases in stress related to the pandemic. they're also reporting that the pandemic itself is a pretty significant stressor. And the Kaiser Family Foundation study recently reported that 4 in 10 adults reported experiencing an increase in anxiety and depression in 2020. And that's compared to 1 in 10 in 2019. So we're definitely seeing increases in anxiety and depression for adults through the pandemic. The Pulse survey also showed a trend upward. So in 2019, adults 18 and over reported about 11% of the time having anxiety or depression symptoms. The August 2020 data showed a jump to 36%, and the February 2021 reporting showed it up just under 42%. And of those people that are reporting that they're having anxiety and depression symptoms, 1 in 4 say that they were not able to get help that they needed. So we definitely have people out in the community not getting support. For youth, people under the age of 18, we have the Youth Risk of Behavior survey, which our town participates in. So we get data from this. Right now we have 2019 data to look at, and we will have this pre-COVID baseline to compare to. But what it was showing in the 2019 data was that there were pretty significant increases in sadness and hopelessness for teenagers from the 2009 data point to 2019, as well as with suicidal ideation that increased. The good thing about the 2021 YRBS is that it'll be collecting more information about how the impact of COVID-19 on families and household, financial insecurity and things like that. We'll have a little more information. We also know that mental health emergency room visits have increased substantially for youth. So overall, children and adolescents are visiting the emergency room for physical ailments, much less over the pandemic, much less injuries. You think about sports have been tabled, things like that. But for mental health evaluations, the August to October 2020 data showed a 24% increase for 5 to 11-year-olds and a 31% increase for 12 to 17-year-olds. And, I can say pre-pandemic, we were struggling here in the state with having enough inpatient beds and program availability for children. So we were already seeing a real lag in people being able to get access to inpatient beds pre-pandemic. Now we're seeing people have much longer wait times, sometimes weeks. And certainly some people are getting boarded in the emergency room. So they're waiting in the emergency room for that inpatient bed to open up. And as a matter of fact, I had a client recently who waited 5 days in the ER to get to an inpatient bed. Mental Health America reports yearly data, and they break it down by state. So we know that for 2020, about 4% of youth had a substance use disorder diagnosis. About 14% had at least one major depressive episode in the last year. 8.5% had a severe major episode in the last year. So these are people who have pretty significant symptoms of depression as well as suicidal ideation. And of those people, 61.2% with depressive episode didn't get services that they needed. So there's a whole huge gap of people, that need care and aren't getting it. We know there's worsening trends. We don't have a lot yet to tell us about exactly, very clear pictures about how the pandemic is impacting mental health. But we certainly know that isolation and loneliness is playing into this, that with quarantining, with kind of the restrictions that we've had, there's a wealth of research that talks about isolation and loneliness, increasing depression and other mental health issues for people. We know that people are suffering from job loss and income insecurity, which increases stressors and anxiety for people. parenting stress is, through the roof in this last year or so, and we certainly know that parents have struggled to manage with the lack of childcare, with needing to manage schooling and also supporting their children's physical and mental health as well. Racial disparity plays into this. There's, with everything going on as far as, protests and thinking about, safety in communities of color, that adds a whole level of stress. And sometimes, real trauma to folks who are living through that. But also within physical health and mental health, there's definite gaps for people of color in accessing care. We know that essential workers have really been impacted by the pandemic. The level of trauma that they've experienced is certainly led to an increase in depression and suicidality amongst essential workers. We know that folks are struggling with loss and bereavement, whether by loss of a family member or friend from COVID or another illness. But people aren't able to grieve and kind of move through the rituals of grief and loss the way that we're used to doing it. And that's been impacting people. And we certainly know that COVID-19 and exposure to it can create stress or diagnosis and then, dealing with the associated symptoms. And certainly for people who are the quote unquote long haulers, we're starting to really see some cognitive and neurological issues that are showing up for those folks that are leading also to, just dealing with chronic illness and the anxiety and depression that can come from that. So again, with the Kaiser Family Foundation study, they really targeted some questions to people about how the pandemic is negatively impacting their life. And they certainly saw an increase in difficulties. 36% of people reported an increase in sleep difficulty, 32% reported issues with eating changes, 12% reported increased use of alcohol or substances, and 12% reported worsening chronic health conditions. And we certainly know that physical health and mental health are really connected to one another. And certainly with anxiety and depression, the diagnostic criteria points to some of these physical symptoms like sleep and eating changes. And we worry about people who struggle with alcohol or substance use because it negatively impacts these other mental health issues. This study also pointed to particular groups that need to be paid attention to more carefully. Age groups 18 to 29, 30 to 39, and 60 to 69 were particularly high in rating a lot of these negative symptoms. Parents, especially mothers with children, people of color, and essential workers are all groups that probably require some significant consideration and care. So why should we consider mental health a public health issue? The World Health Organization views mental health as a really essential component of physical health. And they reported recently that over the pandemic, 93% of countries worldwide have experienced mental health disruption, including in the US. And in fact, a lot of the mental health services here have just shifted to telehealth, which is great because we have been able to continue our work with people. But for those folks who don't have access or have struggled to access or even to engage in their care, via video, there's a growing gap there for those people. It's also important to know that former studies about other diseases have really shown a historical link between large disease outbreaks and worsening mental health. And they've also noted that the psychological distress from these events can be experienced, so people can kind of live in that distress for 3 or more years after the disaster ends. So this is kind of going to continue rolling forward. And I think, in the field, we reference the adverse childhood experience study a lot. And that's a study that really looked at adverse experiences that happen in childhood and what is the long-term impact. So it demonstrated that the number of adverse childhood experiences like divorce or the loss or death of a loved one or the diagnosis of a mental illness in a parent, and there's many other things on that list, the more of those ACEs somebody has, the likelihood that their mental health concerns increase, their physical health is poorer in their lifetime, that they have a shorter lifespan, and that we have increased economic costs due to that. I think if we approach mental health from a public health perspective for the general population, we can also really support the idea of mental health parity, which is this idea that we have mental health brought to the level of physical health and wellness, that there's validity in talking about that and getting treatment, and also supporting the idea that those mental health supports and services should be funded and put forward and prioritized for people. It also helps really bridge the gap for people who don't have access to care or maybe struggle to have access to care. That if we can help those people kind of get in the direction of what they need, whether it's through information, resources, or screening, or other initiatives, then we can start to really help more of those people that I talked about, that 1 in 4 adults or the 61% of kids that aren't getting services get the support that they need. And it also helps us really point to building individual resilience and community resilience. So if I can be more resilient as a person because I have more supports, and the community can be one of those, if our town can have, more supportive mental health services, that might make me more resilient. And if our town starts to focus on these things and talk a little bit more about how to best consider mental health supports, then when disasters or other hard times come, we are more resilient as a community. We can step in with early intervention and prevention sooner. So public health experts recommend a lot of different things, a lot of different approaches. And I kind of pulled some that I think apply best to our town, because we aren't a big urban center. And one of the things that I thought is really important is to understand that we don't have to have, all of us in this town don't have to have mental health expertise or credentials to kind of do this work. Training non-professionals in interventions like psychological first aid, this is something that's been done in many communities. Police, fire, nurses, faith-based leaders, lots of different people in communities can get trained in psychological first aid. And it helps just meet people where they're at if they're in a moment of crisis or if there's something going on that they need support with. Towns can develop digital and social media supports so people can have access to them at almost any time if they have access to the internet. So offering information up online, offering different things via social media that just kind of keeps the information flowing and talks a little bit about the supports that are available. Community-wide information campaigns, offering speakers, offering psychoeducation materials, just keeping the conversation going, letting people know about different initiatives or programs that are out there. Surveillance and data collection, which can be done in a myriad different ways. But I think at the very least, and given what I listened to you all speak about just prior to my talk, it sounds like collecting a little data about who's asking for referrals and support from our town already. How many encounters are the social workers at school having with students? There's things that we could start now or maybe build into some data collection to have a greater sense of what our town really needs. We could potentially offer mental health screening and referrals. We already do offer connection to a referral network, the William James Interface, which is a free referral network where anybody in the town can call and be connected with a licensed provider who will do an intake, gather a little information, and help find a provider who is available to see them. I last heard, I think the turnaround was 2-3 weeks, which I think is pretty excellent, given that lots of people are booked up right now. We could increase supports for basic needs. Our town already provides support in a lot of these areas, but we could assess a little bit more or maintain or bolster up the support for basic needs. So housing, food assistance, heating assistance, things like that. And technology training. I think the world of mental health has seen things shift online, and I'm not sure that that's going to go away. And so for people who really don't have the skill or access to get online or to use technology for mental health supports, having that training being offered to the general public can be a huge support. It could really close a gap there. So I did a pretty cursory look at what other towns in Massachusetts have to offer. So by no means a real deep dive, but Nantucket, their website has a dedicated behavioral health page with lots of different educational materials. They have resource links. They have lots of different, just materials on, advocacy and things like that. But they also have something called a care guide, which is it's a database, an online database on their website where you could click and choose an issue, just as an example, depression, and it'll start to give you some more information. You'll get materials about how does depression feel, what are the symptoms to look for, what treatments work best for it, what medications, and here are some links to some providers who can help you with that. The town of Lexington has a mental health task force. I happen to have my office in Lexington, so I'm pretty familiar with them. And one of the things that I think has been really helpful there is that the mental health task force really linked with the public schools and other community providers, programs, to really reach out to providers in town. So they host, when we can all be in person, they generally host yearly an event where providers can come and meet town, the school folks, they can meet the people in the health department, and we can all talk about the supports and services we offer. They also have a column in their town newspaper, that we can submit as providers. We can submit an article on our area of expertise to provide some education to the town at large. And there's usually speakers, and the other big thing that they do is they compile every year a list of in-town providers, contact information and areas of expertise and things like that. And the schools send that home for families at the start of every school year. In Littleton, we have the Elder and Human Services Department, our schools and fire and police departments that all do some level of training and support on certain areas of mental health. With regard to substance abuse, the fire and police departments are trained with Narcan and they kind of identify substance use issues. But each of these departments kind of target some point of mental health. Like I mentioned before, we do provide referrals to the interface service. We do provide basic needs assistance, and we do have mental health professionals on staff at both the Elder and Human Services Department and in the schools, and maybe elsewhere, but those are the folks that I know. The school system has the Wellness Committee, which meets every month to talk about mental health and wellness. And they also kind of filter in information about mental health into the curriculum throughout the year. Recently, the public schools offered a presentation at the school committee about the mental health supports that they currently offer. Was pretty, they just offered a list of the things that they do. And I think we can't, look past the fact that we have a very active community and we have very active faith-based groups. And I think both of those are very important, stakeholders to pay attention to, because reaching out to the community and getting support there and having community groups and having faith-based groups step in can often be a way to kind of bolster the support in town. I think as you kind of think about this information that I've shared with you tonight, it's important as you're fleshing out how you want to approach this and move forward and thinking about it to tap into areas of people who have areas of expertise in many places. So more than just, more than just me. But people who have mental health, public health, and human services expertise who can really sit down and assess and research and then formulate a really good plan that fits Littleton. I think communication is going to be huge when it comes to trying to be, really on top of helping and supporting people. I think if communication is transparent across boards and departments, and that it's the information that's gathered is disseminated out into different areas of the residents of town, I think that people will have a higher likelihood of engaging in services and getting the support that they need. And, as far as resources go, I know funding is always an issue, but I think it's important to first sit down and think about, okay, what do we have at our disposal already? And how can we cross connect on initiatives, and how can we, focus in on what we have? And it's not about starting over from scratch, just kind of building upon what we need. And then really considering from there whether grant funds are available, or if there's something you might want to ask for in the budget from there. So I could not fit all of my references on the slide I provided you guys, with a pretty long list. And if anybody's watching this at home tonight and you really want a copy of the reference list to really read all that data yourself, please feel free to email me, and we can go from there. All right, so I'm going to stop sharing my screen here. I'm not sure if you guys have any questions for me.
That's a big topic to talk about, so I'm sure we're going to need more time to discuss.
I would imagine so.
yeah, about everything. LCTV has quite a bit of referral information, and isn't the state run Buoy B-O-E-Y?
I don't know BOEY, but I should look at it and see. I could look at it.
All right.
And see that, yeah.
Yeah, and I was just wondering, Mike, if you think that something like this is probably something that should be headed underneath the health department. Could the director of public health or a sanitarium, do they deal with public health and mental health?
They certainly do.
Mm-hmm.
I mean, there was so much packed into this presentation that it would almost be a session unto itself. I think it would be very, very useful if we could make sure that everything that we've heard tonight from Jim, Katrina, and Amy, and what else happens, I hope that the members, shall we say, replay the video at the very least, maybe more than once, and also take advantage of her offer, because I'm going to try to figure out how to get those references. I have managed to scan some of the material that having to do with mental health for other reasons, mainly connected with COVID, almost exclusively with COVID. And the other thing is what I'm used to in this town is how many things are siloed. For example, the public schools really are siloed away from other parts of the town. It's almost as if it's a little kingdom unto itself. And I think there's been a breakthrough with COVID where the connection between ourselves, the Board of Health, and the school committee we've established a relationship with them. And I think that's something we can nurture and move along, because I think Amy hit it. It's without knowing the granularity of the data as it applies to Littleton, I'm pretty sure that there's a worthy set of programs that we could be looking at in the near future. The only question I have is that what I think Amy presented was primarily national data. And it was very interesting because there's some interesting facts about Massachusetts that I did not appreciate until I took a closer look, that we rank third in many categories of having, shall we say, very good mental health, shall we say, facilities to address problems. I'm not going to go into detail. The other piece of this is I'd like to hear from other board members, because not everybody might be equally enthusiastic. and may want to hear more. And I'd also like to hear a little bit from Jim, because he would be an integral part of anything going forward in, shall we say, the very near future, which is what we're in right now.
Anybody? Kevin? Go ahead, Kevin.
I mean, the one thing that really sort of stuck out at me was the, the mental health task force that Lexington has, and coupled with all the great resources that we have here, like the elderly human services folks, Ashley, maybe some of the school nurses, the fire department and police, and Littleton High School Wellness Committee. Wouldn't it be something if we got a team of those folks together to sort of start the conversation and get some ideas rolling and see how we can sort of help do some preventative maintenance and prophylactic measures to see what's going to be coming down the road in the next year or 2, 3 years, as it could be, Amy said, when we sort of see the effects of the pandemic on the mental health.
All right. Dan, did you have anything you wanted to add, or go ahead?
One, obviously, thank you so much, Amy, for a lot of information. As a clinician, I see it all the time, both in the ambulance and the emergency department. That you had a client who had only 5 days in the emergency department is actually not very long compared to a lot of the patients that we see in the pediatric population. We're looking at weeks on end. So it's obviously a huge problem. Here in town, we certainly can deal with acute pretty well. Our police department is well trained and particularly thoughtful. The fire department as well. Those acute situations we can often manage, but obviously our goal is to make sure we never get to needing to dial 911 for a mental health emergency. And the idea of actually bringing some of those folks together, because again, our joke is always every patient is a behavioral health patient, because we all bring stuff with us all the time. It's just part of who we are, and we're just waiting for what our trigger is going to be. And we recognize schools, again, that silo piece that Mike mentioned is a significant concern. We have great clinicians in schools working with kids, but not necessarily working with the family. Elder and human services working with the population, but not necessarily that bigger group, and how we interact. And definitely along with Kevin, if we can pull together a group so we can actually identify those trends across populations and come up with plans of how we can do it. Budget obviously doesn't exist, but education is important and can be expensive, but it can be done well, and it can be done on a shoestring if you have the right people. All the work you put into this, we would never ask you to do this again. But those kind of things, that we can get great volunteers who can share some of their expertise where we might not be able to do otherwise. But pulling it together, what really is going to be the biggest bang for our buck, a bang for our time, to be effective and hit the most folks and get them into the services they need early, so they never need to dial 911. They never need to talk to the school counselor. We can address some of these things early and just let them know that, one, it's okay, and we all are going through things, and that working on the stigma piece is critical across the board. And how do we work those pieces together? So I really appreciate yours. I completely agree. I think trying to find a way for us to, across all the departments here in town, how we can work together to share knowledge, skills, and address a community-wide initiative somehow is critical. I would ask Jim, certainly that mental health has always been part of the nursing side and public health side. Is there any, obviously we know how busy all of your staff are, and certainly in the last year with COVID, but prior to that, again, mental health is not new. Has there been any initiatives from the Neshoba side of addressing community level challenges, access to care, access to resources, either within individual communities or within the Neshoba group?
To the extent that we're able to do things, it's always on a regional basis, and sometimes that presents its own challenge. There was a time where we were pretty happy with ourselves in that we had hired a social worker to help with hoarding issues. Unfortunately, it didn't stay long, but all of a sudden, a hoarding issue in 1 or 2 towns, it takes up the time of a full-time person sometimes. And so that sometimes that in and of itself makes it very difficult to provide the number of staff we would actually be able to have be able to actually provide it for a number of different communities. I think the other part, I mean, the presentation was wonderful. Lots of information that I had not even considered. I think that's part of where maybe the board wants to be at first, is that task force to put together what it is you want to try to concentrate on. One of the things we were looking at with the grant was to try to find try to get a person who could be a community educator. Again, we're all running around doing stuff. Nobody really has time to be thoughtful and put stuff together and that's something we noticed profoundly during COVID. And so we really, in that position, if we had our druthers, we'd probably try to get an LPN or a nurse to help us with that. So both the education piece of it and hopefully kind of some of that mental health piece of it that might help us provide some of that education piece. So that, again, it's a challenge for us trying to do it on a regional basis. And I think identifying what it is you'd like to do so that whatever resources you may have, you can target will be important.
Maybe think like sorry to throw this all on you, Amy, but you probably know more professionals in town, just like Katrina and Kevin Davis, and they had a group together earlier that was similar, like-minded, have some different talents. Maybe if you wouldn't mind reaching out, maybe if you could gather up some people to talk a little bit more, maybe they know how to do this kind of thing, get started in town, a program.
I'm happy to put some feelers out. Yep. And
Okay.
see what people think. Yep.
All right. So will to be continued, but I don't know if you guys want to go ahead, Kevin.
Would it be appropriate for someone on the Board of Health to reach out to someone in the schools, like maybe a nurse or someone on the fire department, or maybe Dan, you probably might know someone on the fire department, or our Chief Bernard with the police department who might have some expertise in this, gone through the training and sort of knows what to look for, that might have some time to volunteer to join said task force.
You talking to Dan?
I was talking to you.
Oh, me? Yeah, sure. Why not? Yeah. I can do that. I can call Matt. I think that they were already on with some mental health professionals, or maybe it was Ashley on LCTV talking about some resources that people could reach out to. So I'll ask him to maybe join us when we have the next discussion on this. So I'll let him know.
And it was Lynn Snow who did the presentation for the school. So I don't know. And she had all of that, every school's information, because they all kind of do things a little bit differently based on age group. So I'm not sure if she might be the best person to reach out to initially, just to kind of get a sense of what's going on in the schools and who to talk to.
Okay. I can talk to Lynn. All right. Does anybody have any questions or comments before we move on?
Thank you, Amy.
Thank you, Amy.
You're welcome. Anytime.
Okay. Thank you. Moving on to correspondence. I got one letter from the Littleton Country Gardeners thanking us for our role in approving the process of their plant sale last weekend. It sounds like it was very successful. So that's good. And also, Jim, I emailed you that buy next thing. I don't know if you saw it during the meeting.
I saw that you emailed it. I'll take a look at it.
All right. Is that testing, or is that
those are the antigen tests, if I understand correctly?
Oh, okay.
Yeah.
So it looks like they're lasting a little bit longer or something like that. And then you saw the agriculture.
I did. So I'm going to try to sit in on that.
Okay.
I mean, a lot of our smaller communities that still have farming are kind of sensitive to that anyway. And I know whenever we're working with boards of health on regulations, particularly with agricultural type regulations, public hearings are always nice because you can get kind of the feel of what the public's thinking about the regulations. So I'll be curious to see what it is, what that means, what they're trying to do with that.
Did the rest of the board see that?
No.
Jim, can you review that just briefly?
I don't know enough about it, Lisa, I'm
Okay.
sorry. Yep.
All right.
If you're going to change a local regulation, you need to run it by the agricultural.
Yeah.
Right.
first.
Yeah.
I think,
Local regulation meaning something about agriculture or any kind of local?
I think anything in general.
I think if it affects farming or animal keeping in the town. So some communities have the keeping of chicken regulations or pigs or stable regs, extensive. And so, to the extent that it may impact agriculture, I think they want to have buy-in on that. So again, there's a presentation coming up. I guess that's why I figured I would end up finding out more about it.
All right. We're not talking stable fees or anything, do you think?
Well, that would be something that you would establish anyway. So but if you were going to, let's say you're going to revise regulations and maybe not allow certain type of agriculture or not allow, sometimes roosters get to be a nuisance in communities. And so sometimes you get regulations where they do. So I think things like that, they want probably a broader consideration of those regulations.
Okay. All right. Anybody else have correspondence that they want to talk about? Okay, we'll move on to member comments.
I just look forward to the next 3 years and working with you guys to do the best we can to protect public health.
Great. Thank you. Go ahead, Dan.
Thanks. Sorry, I'm the new guy, so I also look forward to 3 exciting years. I'm going to have a bunch of questions. I'm very, very familiar with Board of Health operations, but I am not familiar with Littleton's Board of Health quite the same way. As we all know, there's 351 of us, and we are all doing our own thing, our own way. So it's going to be unlearning some old stuff and learning some new things. So I had a couple quick questions. Hopefully you guys can help me out real quick. Does the board have a handbook or standard operating procedures? Do we have a list of standard conditions for variances or for permits, those kind of things? And if you have it, can I get a copy, please? I'm not sure if that would come from Janet, probably is the keeper of the paperwork. That was my guess, just making sure.
Janet, yep.
Do we have a parliamentary procedure standard that we use?
I have a handbook that's pretty lengthy that I think at this point is electronic, so I can give you a paper copy and I can also give you an electronic copy and we can start from there.
Electronic is awesome. Thank you so much. I went back and looked through the minutes that were accessible on the town website. Do we do tobacco compliance? I could not find any reference to tobacco compliance checks in our minutes. So I was curious if we have anything, how often, what's our process?
Yes, we have a Tobacco Control Alliance organization that we utilize for our region. And she keeps tabs on stuff. We do have tobacco licensing on an annual basis that gets initiated through the office, through me. But she keeps tabs on compliance with that and receives an email from me with who has renewed their license and who has not. And then they are the ones who are responsible. I think they do 2 spot checks a year, if I'm correct. We did a change in regulations in 2018, 19. But I can show you that information as well.
Oh, that's great. I looked back to the minutes and couldn't find it, so I just wanted to see what our process was. And
it's been a while. Great. And Dan, we can certainly, set up a time for you to come in the office and go through whatever that kind of stuff you want to look through.
Okay, nope, that would be great. And the last thing, I've been listening in, but I've not been a member of the board as we've looked at our relationship with the Neshoba associated boards, and certainly after talking to Mass Association tonight and some of their information, I guess I have a couple questions. It seems like the impetus, and correct me if I'm wrong, to look at moving in-house with our health department inspectors, public health, nursing piece was really around, it sounded like accountability and data collection and data sharing. And I guess my question would be, if that is our our end goal. Our end goal is accountability and communication of information. Is it a possibility that that may be something we could work on and try to address that challenge rather than starting from scratch?
I can answer that. Unless, Lisa, would you like to do that
Go
one?
ahead, Mike. No, go ahead.
The original impetus had nothing to do with the above. Okay. Okay. As clerk, I was handed the job of trying to determine what was going on. Full simple. In other words, what was the Board of Health and how we were operating. And it was during the course of the action that that the emphasis turned on more with what we had, what we were not paying attention as a board, what we had and what we were not paying attention to, and to what extent could we, as it were, where were the holes and what could we do about them? What is the best way to do it? And the decision to consider moving away from Neshoba or not, still, it turned out, does not change the fact that this board and basically the public health effort in Littleton has to do a much better job of accountability, tracking what's going on, understanding what's going on, and being more, shall we say, more serious about our role in providing public health to the town. So in other words, the original impetus was frankly much narrower, and focus more on the flow of money and not on what emerged, which was improving public health. So I don't know if you picked that up during the discussion earlier with the other Mike who attended here, but as you can hear, the notion of moving away from Neshoba is not, shall we say, it's not cast in stone, because even if tomorrow or next year, the year after we did so, we would still have to do the process that we've already started, which is simply doing a better job of working with what we have. We have to start there. We have to, as it were, not reinvent the wheel, but make better use of the wheel we have. Then I think we'll be in a better position to understand what is our next step. Does that help, Mike? Does that help you, Dan?
Well, I think I certainly understand the concern, and certainly prior to joining the board, I pulled some information, requested inspection records for a random collection of things here in town, and from what was provided, that we're not in compliance as a board or as a department with our legal mandate around some of our jobs as a board and as a department. So certainly looking at how do we look at accountability is critical. How do we make sure that we're providing our legal oversight of our paid professional staff, Neshoba, that they are meeting the legal obligations of inspections every 6 months and those pieces, and providing that information back to us. I guess my question or my observation is that we already have now basically put a warrant article onto town meeting to start the process to leave Neshoba. And it's going to be on the floor of town meeting in a few months that's the warrant. Is that part of the warrant? Is it, do we or don't we?
Excuse me. What was submitted is a draft. It had to be approved by the select board to go on the warrant. There are other elements in the request beyond. Mm-hmm. So it's not yet settled whether or not it's going to appear in the warrant as it is. Right?
Okay. So that's coming out of the Board of Health. So we need to decide whether we support continuing with that for this warrant, or whether we need to request that it comes off the warrant as we gather more information. Is that once it's to town meeting and it's voted on, yay or nay, if the choice of town is to say we need to start pulling out, we have a year to be up and running independently, and that's a big shift.
No, I all that would do would trigger a decision to be made. Shall we say we could authorize? Theoretically, we could, if the town voted yes to withdraw from our association with Neshoba, all that is, it's the authorization to do so. It doesn't mean it gets executed that day or the year following or the year following. It simply gives the Board of Selectmen the opportunity to do so. Full stop.
Okay.
Because from just to add, if the last time we had a presentation to the Board of Selectmen, it was very clear that we had to go through a transition period, and the transition period consisted of, shall we say, taking seriously just the very issues you mentioned, accountability, among others. So in other words, the Board of Selectmen already understands very clearly that the withdrawal is not going to occur immediately if it occurs at all.
Sorry.
Go ahead, Kevin.
Quick question, but it would allow us to have a line item budget from the select board to be able to determine our next steps in moving forward, whether it be in a transitional manner or however we decide as a board to move forward. There's some financials allocated there through that warrant, correct?
There's a line item request for funds for communication to the community that we don't have, that will, shall we say, address certain emergency situations that we simply don't have and totally inadequate. That's what this board approved of earlier.
In the short term, are there ways that we can work with Jim and his team to improve sharing of communication, sharing information, and accountability so that we can get the information that we need to make sure that we are in compliance and we can be successful?
We've already started that process. In fact, as you may have heard tonight, and I was waiting for the right moment, this is it, that the addition of staff to Neshoba, Jim has indicated that one of the issues has been, and he said he's going to address it with the assistance he's getting from the new hire, to provide, shall we say, more service to Littleton in accordance with our need, because again, we are anticipating an increased pace of housing developments and all the rest, quite aside from the, shall we say, the larger programs near the, in the common or near the rail station. Just what we have, just the projects that we have ongoing now could very well stress what would have been the ability of Jim to hit all the marks for the town in his usual professional manner. So the addition of that. The second thing that's happened is that there's going to be shall we say, a much improved communication of the flow of information between his offices in Air and our offices here in Littleton. And that's already been incorporated, as it were, into the plan and logistics that the town is setting up in the town hall. Within the, I think it says within in land use and building, that is going to be a administrative center for a lot of data coming in so it can be shared among all the relevant departments. And that will be the center of improved logistics and interaction with the group at Neshoba.
Okay, so Jim's going to be providing reports of department activities within the town of Littleton on a monthly basis, quarterly basis, or?
The agreement will be that we will electronically receive on the day of submission all requests that come in across the board for service, and also making sure that what comes back and progress as each project moves along will also be electronically shared with the offices in Littleton, which at the moment is not occurring, and also making sure that the final resolution of some of these tasks are provided in Littleton, but in a form which is useful to be shared among all the other relevant departments, which at the moment, Littleton itself did not have that capability, but now we're going to be having it.
Okay, so that sounds like it's Title V and building projects and those kind of pieces. What about the public health data and restaurant inspections, school inspections, that data as well? Is that going through the same process through
yes,
projects?
it's going to be basically, there's going to be a center of administration as passed already by the select board. There's going to be a center in which such data are going to be, shall we say, provided and readily available.
Go ahead, Kevin.
Yeah, the OpenGov viewpoint software that the building department uses can be tailored to also be utilized by the Board of Health. And I've spoken to the building commissioner, and he's happy to give the board a tutorial on it. And I'm sure we can customize it to get like the wastewater treatment plant reports included in that. And if you have any thoughts on different public health metrics that we might be able to pull up reports on, that we can get the data in there, maybe we can work together to get reports, monthly, quarterly, whatever might work out of that system too.
Okay. Is that the same system that Jim's using, so that we're not having lots of folks put data in? I hate double documentation. I'm a nurse. We hate writing the same thing twice. So
I don't know what Jim uses.
How is Jim tracking the work his staff is doing across so many different really disciplines in his office?
So, and I've shared this with Mike, because towns use different types of software, it's hard for us to have a particular software that we're using, so we use, we have an activities database. So when the staff goes out and does certain activities, they do a day sheet at the end of the day, those go into an access database. We can pull it by time frames. One of the things, part of the grant, both looking for a part-time food inspector and looking for the food service database, inspectional database software to go out and actually do the inspections and save the reports. And so, that's part of what we're looking at to try to improve that piece of it. But again, even those, there are 2 or 3 different, large inspectional softwares for boards of health to use. We looked at towns nearby and what they were using and how they liked it, and tried to pick something that would be appropriate for us.
Even short term, it sounds like you could run a Littleton and a time window and generate a report of activity in town across your disciplines: public health, contact tracing, food inspections. Sounds like it's pretty easily done.
Some of that stuff, sure. So, yep.
Okay. So that may be an easy place that we can start, at least seeing what activities are going on in Littleton on behalf of the Littleton Board of Health by Jim and your team. That might be a good starting point of starting some of that visibility and accountability of what's going on in our town that isn't necessarily as visible. If that would be possible by, obviously you have lots of towns to work on, but I'm hoping running a quick access database query once a month for Littleton in a month wouldn't hopefully be too onerous.
It certainly wouldn't seem to be.
No, that would be great if that would be possible. If it's at obviously the pleasure of the board.
Sounds good.
Yep, we can work on that.
All right.
All right.
Sorry, I was chatty. I think that's all I have for now.
Any other member comments? I guess I have a question whether or not you guys want to go back to 2nd and 4th weeks of the month. You think it's appropriate to go back to that now? Or do you want to keep on doing once a week? Anybody? No comments? All right. And then,
Kevin, I'm surprised that you don't have a thought about this.
On the one hand, it'd be great to have every other Wednesday off. But on the other hand, I feel like we have a lot more work to do now than we have had in the past. And we should probably just keep it on weeklies. I don't know.
okay.
Speaking of a lot more work, I don't want to get ahead of anybody, but I believe by customer, we're looking at reorganization at some point.
Yep. We can't do it tonight because it's not on the agenda.
I agree. No, I agree. I just want to.
Lisa hasn't had a year yet.
I'm sorry?
Lisa got delayed a couple months. She's got a couple more months in the saddle before We have to reorg.
Like 52 weeks, 52 meetings in a row, guys. Yeah, well, we can put that on the agenda. If you don't want to do it next time, we can do it in a month or whatever you want to do. All right, and then Janet's probably interested in this. Going forward, anybody taking vacations so that we can see what we've got for quorums on meeting nights. So,
By the way, I'm one member who would be very happy to proceed without necessarily reorganizing. We have a lot in front of us.
what are you saying, Mike?
I'm saying you can wait 1 week, 2 weeks, 3 weeks.
Oh, for reorganizing.
Yeah, I mean,
Consistency is nice.
Yeah.
Well, we should at least vote in a vice chair.
What are you? Yeah. Well, wait a minute.
Lisa's not sure she wants to just do
I'm not sure if I want to. Not every week.
We'll discuss next meeting. How about
We
that?
can discuss it some more. So we'll.
Fresh eyes.
Should we put on reorganization on next week's meeting, and then touch on it, or we made a decision, or we guys can talk? We can talk about discussion of reorganization of the board. How's that? All right. And then let Janet know if you guys have weeks off that you're not going to be available. And any other comments? Member comments? All right. Any public comments? So we've got a late meeting tonight. We still have a few people here. Any member comments? Maybe everybody's fallen asleep.
No hands are up, Lisa.
Okay. All right. Who would like to adjourn tonight's meeting? Make a motion to adjourn.
Make a motion to adjourn.
And a second?
Second.
All right, we'll go by roll call. Kevin Baker,
Kevin Baker, yes.
Fratelloni,
Gino, yes.
Dan Kane,
Dan Kane, yes.
Mike Zeldin,
Mike Selden, yes.
and Lisa Flanagan, yes. All right, so,